All right, we're going to get started. Good morning, everybody. My name is Robert Gross. I'm from the University of Pennsylvania. Welcome to the course on adherence to medication. I want to welcome everybody on behalf of our course director, Jacqueline Huchtenberg, from the University of Curaçao and VU University Medical Center in Amsterdam, and Julie Laufenberger from Brigham and Women's Hospital in Boston. My disclosure is that I'm a consultant to Pfizer. I'm a DSMB member for investigational medications, and my service on the DSMB is unrelated to medication adherence or to this presentation. Some educational objectives for this morning are to understand the different constructs of adherence behavior and the different techniques to measure them, to describe strengths and limitations of the various techniques with respect to validity and implementation, to select the measurement techniques that are most appropriate for the research objective, and to understand analysis issues linking adherence with biomedical outcomes and adherence itself as an outcome for intervention studies for those of us who are trying to increase our patients' medication adherence. Just want to see if, so the arrow does show. Okay, great. So a little outline for this course. I'm giving the intro, then Jacqueline will talk about subjective measures of adherence. I'll talk about electronic measures of adherence. Julie will talk about pharmacy measures of adherence, and then we'll have an interactive case study where the three of us will discuss with all of you approaches to the case at hand, how you would design the study, what issues arise for you in your study design, and go through some of the practical issues that arise for medication adherence research. And what we'll do is we'll cluster you folks by area, and we'll have some chairs turned around so you'll be able to interact with each other, and we'll all interact together, and then I'll make some conclusions and wrap up. So outline for this intro is I want to, I guess I shouldn't have to motivate you. You're all motivated. You're here. It's beautiful Halifax, and you've come to stay inside to hear an educational session on measuring adherence. So I suspect you're all motivated and think adherence is an important topic, but just in case you need some more motivation, I'll do a little bit about that. Then I'm going to go into some definitions and terms. There's a lot of language that we use that we need to be super careful about in communicating what we mean by adherence. And I'm going to break down some of the concepts and components into and use the definitions and terms to help us do that. And then we'll talk about other issues to consider and decisions to make that the other presenters are going to go into great detail on. So we know that this is the favorite quote from all adherence researchers in the world, is made by C. Everett Koop, who was the physician-in-chief at Children's Hospital of Philadelphia, which is the sister hospital to University of Pennsylvania. C. Everett Koop said that drugs don't work in people who don't take them, which is an always true aphorism. But we need to also recognize that non-adherence is actually normal behavior. And perfect adherence is actually quite abnormal and unrealistic. And having missed a dose of my medications on vacation last week because I was out of my routine, hopefully I consider myself normal. I exhibited normal behavior by being non-adherent. So it is, we're not talking about aberrant behavior. We're talking about expected behavior, but we've got to deal with it and control for it. There's been extensive research on determinants of adherence, and that's not the topic that we're going to be covering here. But just to summarize, that there are many barriers to adherence and relatively few effective solutions. Although there are some, I've developed one and am working to disseminate it, but it's not straightforward. It's not easy. It's not simple. It's not as easy as shaking people by the shoulders and say, take your medicines to save your life. Biomedical, biobehavioral, and technology-based interventions, especially when they're paired, I think are really exciting, and we're thinking about addressing in a future course. And I put this up every time, and we haven't done it yet, but we're hoping to. And if there is a groundswell of support, we'll mount that course. So why measure adherence? you're all pharmacoepidemiologists interested in confounding variables. It's a key confounding variable. And if you're developing a drug, you risk abandoning an efficacious drug that people aren't taking because you study it and it doesn't work. Well, the drug doesn't work, abandon it. In fact, people just weren't taking it, and you might miss the point and abandon a useful drug rather than addressing the reason why people aren't taking it. There are other mechanisms by which a drug might not be working. It might be poorly absorbed, and people taking it in clinical settings may not be behaving in the same way as in clinical trials, maybe taking it with food when they're not meant to, taking it with antacids, taking it with other binders that might get in the way of absorption, and you might ascribe it to poor adherence, or vice versa. So if you're not measuring adherence, you don't know which of those is going on. Adherence is a determinant of interest for people like me who are looking for thresholds. How much adherence does an individual need for this drug to work? And it likely varies by drug. There's probably no one threshold for drugs. And you can then relate their adherence with other behaviors to see if you can impact, say, depression or behaviors surrounding substance use, et cetera, and how they impact adherence, and then intervene on those to improve outcomes. And then it can be a variable of interest. If you are someone who wants to intervene and are doing health services research, then adherence obviously has to be measured because it's your outcome of your study. So here's some of the definitions. Adherence is defined as the extent to which an individual's behavior regarding a medical treatment regimen corresponds with the agreed upon recommendations of a healthcare professional. Now, we try not to use the term compliance, and this is, you can consider this either political correctness, that we're not trying to stigmatize the patient, or you can consider it a way of paying attention to the drivers of adherence and not simply blaming the client or the patient for the problem. And so by calling it compliance, the word in English comes from the word from bending to the will of another. It's not really the doctor's will. It's really the patient's success with their treatment that matters. And so we're not so much looking in a paternalistic way for obeying what the doctor's doing. And so try to get away from the word compliance and use adherence, which is really much more of a neutral term of sticking to medications, and suggests more collaboration between the healthcare professional and patient, and is a much more modern approach. And so we much prefer that term. Here's a conceptual framework of the actual process itself, where it starts with the patient at the top of the pyramid, but then there are also their family and caregivers who are often involved, especially if you're talking about pediatrics or you're talking about the extreme elderly or others who are unable to care for themselves. Their adherence may be determined by others. Certainly their adherence is in part determined by their providers and prescribers who are choosing the medications, and are they choosing a once a day or twice a day or 3 times a day, God forbid, medication, or are they does the provider even initiate treatment? Community institutions then become involved. And then of course healthcare and prescribing policy. I live in the United States where people pay for medications, and that tends to be problematic for a lot of people. Here's the continuum of how we think about adherence to medications, where you have to initiate the medication. That's the first step in adherence, of course, and that might seem obvious, but needs to be studied as its own phenomenon. Then persistence, are they staying on the medication? So this would be non-persistent. The person is not taking the doses here, so this is discontinuation. And then here's implementation or execution. They took this dose, but they missed this dose. They took this one, took it, missed, taken, missed. And that's what we mean by execution. I already talked about primary non-adherence. That's initiation. The prescription is not filled. It's very challenging to study because you need to know what was in the mind of the provider, what was in the mind of the patient, And sometimes you don't even have, most of the time, you don't even have access to data related to whether it was intended for them to be on the medication. So there are some challenges with studying primary non-adherence. You typically need an electronic medical record with e-prescribing to know that a med was prescribed but never filled or taken, etc. But this is critical for short-term therapies. Think about an antibiotic course for an infection. If someone never even showed up, you didn't know that they were even prescribed the med. You didn't know that they didn't initiate it or complete the treatment. Persistence is staying on treatment, and I think this is quite clear to everyone. If someone just decides I'm abandoning therapy and they discontinue it, there's no more doses taken. They're no longer refilling the medication. Now, this is if the provider intends for them to stay on the medication, has continued to prescribe it or thinks they're still on it, and then they stop it, then they're non-adherent because they've discontinued it kind of against the provider's recommendations. If the provider says stop your meds and then you stop your meds, that's not non-adherence. You are adhering to what the prescriber said, which was to discontinue. So you need to tease out whether the provider intends for them to still be on the med and yet they stop it themselves. And the definition or the duration of what persistence is depends on the drug and the disease. Suboptimal execution implementation. This is what most people think about when they think about non-adherence. A person is meant to be on a med. They take it, but they don't really take it great. They don't take it every single time it's meant to be taken. And there are an infinite number of patterns, and I'll go into some of those details. And then classifying the amount of deviation from the prescribed. How much matters? Is 5 minutes late non-adherence? Is 3 hours late non-adherence? Is half a day late non-adherence? All of those definitions depend on the drug and the disease. So you need to really deeply think about your drug disease relationship in considering whether someone is being adherent or not. And then there is something called super compliance or over adherence, where some people take extra doses, which is really problematic. In the old days of anticoagulation with warfarin, I shouldn't say the old days, people still use warfarin. In the days where anticoagulation with warfarin was very common, we studied it and found that there were people who were super diligent, and if they thought they missed a dose, they took an extra dose. They may not have remembered that they took the dose, actually, and then were over adherent and actually were over anticoagulated. So that does occur. It's a much smaller problem, though, than people missing doses. Okay, so some overview of the measurement. We'll go into greater details, and Jacqueline will talk about subjective measures of self-reports. There are many versions. They need patient contact, and Jacqueline will talk in detail about that. And then in terms of objective measures, I'll talk about some of the electronic monitoring measures that require patient contact. And Julie's really going to spend most of the time talking about pharmacy measures, which are what, as Jacqueline likes to say, the core business of people in our field do. How do you decide which drug you're going to study? When you study diseases that are treated like hypertension or diabetes treated with multiple medications, how do you pick the drug? Which drug should you study? Should you study the most important drug in the regimen because it's the most active, or the one that's the hardest to adhere to because you're trying to enrich for the people who are struggling the most? Or do you study the one that's easiest to study? There's an assay for measuring this drug, and it's been validated, and it can easily be done by your lab colleague down the hall. Then you might pick that drug. So those are additional decisions that you'll need to make in designing your studies. And then what about multi-drug regimens? We had a session a few years ago, I can't remember now, it's many years ago, on multi-drug regimens and the challenge to studying them, and it's not been resolved, and it probably differs by setting. So your drug monitoring considerations are, as I just said, your setting. Do you have patient contact, or is this a database study? What's feasible? Does the assay exist that you want for drug concentrations? What are your costs or study resources? What question are you trying to answer? Are you an adherence researcher where you want to nail all the details about adherence, or is it a confounding variable that you can measure with some more error than maybe some of the other key variables? How forgiving is your drug? Forgiveness is the sense that, okay, the person who takes 95% is fine, irrespective of, who they are. Whereas in other diseases, 90% is not acceptable and they need to be at 95%. The 90 to 95% difference might mean that drug is not forgiving of non-adherence. Whereas in general, if you take most of the doses, the drug is forgiving of 20% misses, for example. That's again going to differ by disease and by drug. What about intervals? How long is an adherence interval? Do we study one big period of time, like for the last 5 years, have you been adherent? Do we study the last 3 days? Have you been adherent? How long should that interval be? And you need to pick those. And then should you study multiple intervals? Should you study multiple 3-day intervals? How do they do every 3 days? Or how do they do every 5 years? Those are, again, decisions you'll need to make and can be limited by the frequency of how you're monitoring someone. If you have electronic monitors, you have continuous measures over time. If you're seeing individuals and asking them questions, you only have the periods of time during which you see them because they can't remember for the last 5 years. So if you ask them, how have you been doing with your medications for the last 5 years? You might get an answer. I wouldn't consider it heavily valid. How far from this clinical event should you stagger your adherence measurement? So a person has an MI on a certain date. Do you want to know were they non-adherent for the 3 days before the MI? Or do you want to know for the 5 years before the MI, were they taking their statin? The last 3 days of taking their statin may have been because they were having chest pain and they said, I wonder if this is a heart attack. My doctor gave me a statin to prevent heart attacks. I'm going to take my statin. And so for the last 3 days, they were really adherent. Say, there's no relationship between adherence to the statin and whether or not they developed the MI. If you look back 5 years, of course, they were taking, half of the doses. And so there is a strong relationship between the non-adherence and the MI. So how far upstream should you look for the relationship between adherence and your clinical event? Going to depend on the disease, going to depend on the drug. So to summarize, there are many approaches to measuring adherence. All of them are flawed. You will not leave here saying, oh, well, of course, the perfect way to measure adherence is X. It doesn't exist. But I want to caution you to not throw the baby out with the bathwater. These measures do capture variability in people's adherence. They just don't do it perfectly. And so you have to not expect perfection, but not ignore the variability that you can measure by the techniques that we're going to talk about. And you need to think through the drug-disease relationship. And that's why when we go through some of these exercises, we're going to do it on diabetes, but there are many other examples that you could come up with. And often we'll toss it back to you, say, you know the disease better than we do. Tell us how much adherence is needed. How forgiving is the drug? What is the relationship mechanistically between adherence and outcome that you're hypothesizing? So you'll need all of those to make your design decisions. Okay, so I'm going to stop there. I'm going to hand over to Jacqueline, who's going to talk about subjective measures of adherence.
Thank you, Robert, for the very nice overview and introduction. Welcome, everybody, to my presentation on the use of subjective measures in adherence research within this course. My name is Jacqueline Huchtenburg. I have no disclosures related to this presentation. So today I will talk about how self-report instruments are used and the benefits and limitations of these instruments. And I will show some commonly used questionnaires, and I will talk in more detail about their analysis. And finally, I will show an example of a study using interviews. Subjective measurement techniques are methods to assess adherence most often used both in clinical and research settings. And it is actually simply not more than asking participants to report on their medication adherence behavior. So I could ask you or one of your family members, do you use your medication on a daily basis? Or do you know your family member ever forget to take the medicine? So then you are already interviewing. There are 3 frequently used instruments. For example, using a diary. With a diary, you can ask your respondents to report on a daily basis on the use of their medicines. By means of a questionnaire, you can collect quantitative data on adherence. And by means of interviews, you can ask the questions of the questionnaire, and you can perform a quantitative analysis, but you can also, and that is more often done, use an interview to collect qualitative data. And I will tell a little bit more about that. Well, what do we actually measure with a self-report instrument? You can measure whether a patient passes over a dose, whether they change the dose of their medication, take less or take more, or decide to discontinue the use of the medicines. In these cases, we are talking about intentional non-adherence. We can also ask whether a patient forgets to take 1 or more doses. When do you forget to take your medicine? And this is referred to as non-intentional non-adherence. Another example is when the patient has no opportunity to collect the medication at the pharmacy. For what reason? Because he's too ill or the distance is too long. That's also non-intentional non-adherence. Well, and then think about the determinants. You need to know, if you want to know more about the patients that are non-adherent, because, for example, you want to address these patients you want to include these patients in a particular study, you could investigate the determinants also by using a questionnaire. And this also informs us who you must support and also possibly how you have to support them. Self-report instruments also allow for asking after barriers and patients' reasons for non-adherence. Like side effects, you can ask after a lack of effect of the medication. You can ask whether to what extent they want to use the medication, their motivation for getting, and also practical problems. For example, a tablet can be too big to swallow, and this happens very often. There are some benefits of subjective measures. The questionnaires are simple and quick and easy to administer, and the use of a questionnaire is not intrusive. This does not hold always true for an interview, because patients can feel emotions during interviewing, start crying. That may happen. This really happens. But using an interview, you can elaborate more on the answers of the respondents and ask for more information, and also dive deeper into the reasons for non-adherence. In general, self-report measures are inexpensive, and you can also ask after social, situational, and behavioral determinants for non-adherence. And we can easily distinguish intentional and non-intentional adherence, which we cannot do on the basis of database studies. There are also some disadvantages. Self-report instruments have their limitations, and they are subject to a variety of biases, such as recall bias. While the respondents may be inclined to give socially desirable answers, and also errors may occur. And also think about the response rate. In a database, you have all the patients, but generally the response on a questionnaire is about between 50 and 70, 75%. So you don't have information of the non-respondents most of the time. That's also what we should consider. Respondents may overestimate adherence, and there's a large variety of questionnaires described in the literature for different diseases, and they are often in English, so probably the questionnaire must be translated in your language. You should always also be aware on the capabilities of your respondents to understand the questions in your questionnaire. And often, non-adherent patients are more often less illiterate. And the less illiterate people have difficulties with filling out questionnaires. And some of them already know that from themselves. They say, oh, I am not able to fill out questionnaires. They have learned to say that. And so you will not get the information of these people. And you can also think about how to address that. For example, well, if you are not able to fill out the questionnaire, we will help you. But that also has an effect. Interviewing takes time and can be intrusive, and it also requires training in the technique to adequately conduct interviews. It's not that easy, and also not the analysis, I can tell you. Most often used questionnaires are described in a review by Nguyen et al. They found 43 questionnaires, different questionnaires for measuring adherence. So that's difficult to select one. But most often used questionnaires I present here is the Mars questionnaire, consisting of 5 questions answered on a 5-point Likert scale. Morbidity medication adherence scale, 8 questions simply answered by yes or no. But you must be careful. Morbidity will ask you to pay for it if you want to use it. Then the MAC questionnaire is quite similar to Mars, also 5 questions. Hillbone questionnaire is also often used, but that is specifically for measuring medication adherence in cardiovascular diseases, and also asked after determinants such as lifestyle, because and traveling, and that's interesting and important because we know that often a less favorite lifestyle is associated with less adherence. And sometimes people with an unhealthy lifestyle become ill, and they are those who will not be adherent. So we must take care of that. And traveling is also not an easy situation for using medication. Then people have other things in their mind. They forget their medicines, and they forget the time. They have other priorities when they travel. Okay. Mars questionnaire is a short questionnaire, 5 questions, and it assesses intake behavior, but not the barriers. It is rated on a 5-point Likert scale, and for each question you can get 5 points, so 5 times 5 gives 25 points. and 25 points is considered adherent, and sometimes 24 points also. And these are the simple questions of the Mars questionnaire. I alter the dose of my medicines. I stop taking my medicines for a while. I decide to miss out on a dose of my medicines. I take less of my medicines than instructed. I forget to take my medicines. And you see that questions 1 to 4 are more or less intentional adherence, and 5 is unintentional non-adherence. Well, rating regarding the scales, you should know that there are both generic scales, like Mars, MAC, Morisky, and scales specific for a disease, such as Hillbone. And some also ask after determinants. What you should also note is that you need to provide a careful instruction to fill out the questionnaires, for which time period you ask, do you ever forget to take your medication? Is that the last week or the last 2 weeks or the last month? That people understand. And you should also explain what is a 5-point Likert scale, and it is also mandatory to give an example how you fill out a questionnaire. And finally, test the questionnaire in the population. What I found out last year, we performed a study in a population with lower health literacy, and people did not understand the questions of the Mars questionnaire. And they did not understand what does mean a little bit, very much, and so on. So we trained students to support the people to fill out the questionnaires. And I will show you an example in which we provided these questions to a subset of 3,000 people, and half of them filled it out. But you don't know who didn't understand it. But in this study, it took months to have found 50 people filling out a questionnaire. Well, and something important with using questionnaires is the psychometric properties. And psychometrics is the construction and the validation of the measurement instrument, and assess and do these instruments are they reliable and valid forms to measure adherence? And are they reliable and valid? So it for the Mars, MAC, Morisky, and Hillbone, construct validity has been determined. And the construct validity concerns the involvement of an expert. Are these questions clear? And the content validity is a comparison with the golden standard. For example, for adherence measurements, we compare the outcome of the questionnaires with MEMS, means of electronic monitoring, or other means of electronic monitoring, and comparison with clinical outcomes. And that has only been done for MAC and for the Hillbone, the content validity regarding clinical outcomes. And this should be taken into account when you select your questionnaire, because it can help you to provide the discussion. Well, when you select an instrument, you must think about what you want to know. Take into account how a scale has been validated and in which population. So when you want to compare with other studies, first analyze these studies for yourself. You should also take into account whether the scale can be made available for you. Okay? Can you copy it from the literature without payment? And we also recommend to consult an expert in your studies. Well, a questionnaire can also support clinical care. You can ask your patients whether they are non-adherent. Address this. That can be addressed in consultations, in a consultation or by a questionnaire. And then people who are at risk for non-adherent or say that they are non-adherent can be provided with specific support. And sometimes also in clinical care, it can be useful to combine different methods. For example, a subjective method with an objective method. So look to your data. Does the patient return in time to ask for a follow-up prescription? And it's important to tailor your assistance to the individual needs. I will show you an example of one of our studies in which we asked patients with anxiety and depression to fill out a Mars questionnaire. And we did it in a large cohort study. And the data from this study was the data from the NESTA study. This is an ongoing longitudinal cohort study, including patients with depression, anxiety, and controls. And this cohort, it goes to. And we investigate there the course and the consequence of depressive and anxiety disorders in patients from 16 to 65 years on, longitudinally. And in the analysis, we decided that we used a Mars questionnaire, and we decided that 24 points or 25 points was adherent, and less than 24 points we considered non-adherent. And here we show the patient characteristics of 1,890 people who filled out the Mars questionnaire. And here you see the distribution of the Mars 5 score, and you see that a large part of the people had 24 or 25 points, but there were also people with less than 24 points, and it is very skewed. And totalized, we had 1,063 people we considered adherent, and 827 people we considered non-adherent. And as with data on medication use in a database, either from healthcare providers or health insurances, also with these types of data collected, you can perform epidemiological analysis like univariate and multivariable analysis. And we did this for the outcome of adherence, and we found that younger age was a risk factor for adherence. Younger people were less adherent. And we also found that patients with remitted depression and anxiety and current depression diagnosis and also alcohol dependence was a risk factor for non-adherence. But using antidepressant medication had a protective effect. Then you could also think, is this cutoff of 24, is that okay? Shouldn't we take 23 or 22? So what we did is we repeated the analysis with other cutoffs. And what we found was that the directions of the effects were similar, but with a cutoff of 20 to 22, the association of anxiolytic use and social support with adherence became statistically significant. So sometimes the direction of the effects may be similar, but it can change a little bit, so that some effects that were previously not significant become significant. So, and it's important to perform these sensitivity analysis. Well, in summary about this part, we should notice that subjective measurement and analysis has several challenges. How to score the answers? Do we use yes or no, or a 5-point Likert scale? How to analyze and dichotomize your data is important. What do we consider adherent? What do we consider non-adherent? Or should we use a continuous scale? And the cutoff that you decide to use is very important, but also compare what is done in the literature. If you do something completely different, it will be difficult to compare. And also, you should take into account the environment, the setting. Are people included in specialized care, or in GP practice, or in the pharmacy practice? That may differ and has influence. So I will also provide you with some information on qualitative studies. For qualitative studies, most of the time, an interview individually with participants is performed, but also focus group discussions. And in a focus group discussion, you also include the interaction of the people. Some respondents say something, and the others can react on it. It's also a little bit more efficient. When you have a focus group with 15 people, that takes you 2 hours. 2 hours to note all the all what has been said, to transcribe it. And individual interview generally takes about 3/4 of an hour, and that 15 times takes more time, and also takes more time to analyze it. Okay. Well, yeah, and with qualitative research, you can collect more in-depth information, can be more explorative, and sometimes you can combine quantitative and qualitative research. For example, when you have performed interviews and some findings come up, and you want to know more about in a quantitative way, you can repeat almost the same study in a quantitative way using questionnaires. Well, in the qualitative methods, we use semi-structured questionnaires, so you can also dive a little bit deeper with follow-up questions. It is normally audio recorded. You must ask the participants to agree with that. It is the data is prescribed, encoded, and analyzed, and it is quite challenging to do. I show you one quote from a qualitative study, and what is important is that the interviewer asks, if possible, as much as open-ended questions, because an answer as yes or no doesn't help us so much. So the interviewer says here, okay, yes, and you do also use a reminder or something like that? Or do you put it with the breakfast? Or how do you do that? That's open. How do you do that? And the respondent says, yes, I'll do it every night before I go to bed. I wash myself, and then I put it in the box neatly to the cabinet in the bathroom. So every morning when I go to the bathroom, I see it. But then I always, after washing myself, I'll go to the breakfast, and then I'll come in the bathroom to do the rest. And then I see my box and I will take it. And you see, you get a lot of information. And that's something different than just asking, have you taken your medication? Yes or no? And the last example, the interviewer says, do you ever think about stopping with the tamoxifen? The first year I thought about stopping. And the interviewer said, yes, to motivate the participant to go on with talking. He said, yes. And then, how so? How? Because I had a lot of pain in my body and my body didn't want it anymore. And I had heard of someone who had that too, and they stopped taking it. But then I thought I should continue because that's the preservative of my life. And then you better understand the consideration of a patient, why to take the medication. So I think this was the last slide, and I thank you very much for your attention. And now we have a short break of 10 minutes.
I was going to say, for those of you closer to the back, if you want to move forward just so you can see the slides a little bit better, you're most welcome to. There's like detail on some of the slides when I'm walking through the methods of how you think about how to measure adherence. So if you want to move a little closer just to be able to see better, you're most welcome to. Also, when we have our interactive group work, you'll end up kind of clustering towards the front anyway. All right, we'll go ahead and get going. I just want to apologize in advance if I cough a little bit. I did a really big hike last week and I'm still like recovering from it. But here we are talking about objective measures for measuring adherence. And so this is like the meat of when we think about measuring adherence in pharmacoepidemiology. This is generally what we're referring to. And so we'll take about, if there's questions throughout, feel free to come up to the mic. But we'll take about an hour to cover this, and we'll take another break, and then we'll move into the last kind of didactic piece, and then we'll move into the case study. So it'll be fun. But just to get going, I have no relevant conflicts of information and of interest for this presentation. And what I am covering here specifically is how we go about actually measuring adherence, although we'll come back to what adherence really means again, as introduced by Robert. And first thing, with a lot of the databases that we have access to. Thinking about the different phases of adherence and what we're really interested in, and some fun, more methodologic techniques we now have over the last 5 to 10 years for thinking about how we can measure adherence. And so we'll end there. And so just to start, of course, when we're thinking about objective measures for adherence, as a pharmacoepidemiologist, I think immediately claims, but that isn't actually the full landscape of what we often have available to us to objectively measure adherence. We had just covered subjective measures that came from patients. Now these are objective ones. And so these that I've listed here are the ones we call direct measures, because we are directly observing the level of medication that somebody has. And so there's direct observed therapy, which has been used exhaustively in, say, the tuberculosis space, where you're physically measuring how many pills patients are taking and watching them take it. Obviously very labor intensive, difficult to do. Increasingly, there's kind of these 3 other biochemical type measures that are direct. You'll see sometimes published in the literature. I think they're too nascent still to really be useful, because most of the time they're measuring cross-sectionally how much drug people have in their system. So not still as useful for us as pharmacoepidemiologists, but they exist. And these are things called like serum drug concentrations, biochemical lab markers, and even hair analysis. And they're things that we can use and ask, with informed consent and others directly from patients to see how much level of medication people have and how much they're taking. But again, typically cross-sectional, typically not generalizable, and not things we often do as pharmacoepidemiologists, because we're living in the space of like only being able to get information from dozens to hundreds of patients, as opposed to the millions thousands to millions we often have in the claims or dispensing databases we're working in. All right. So then what is more fun and what we spend more time thinking about is now these indirect measures. So they're indirect because we're kind of proxying what we think in terms of how much medication patients are taking. So before we had electronic databases, we typically relied on pill counts. And in low resource settings, we still often are living in a space of counting pills and counting how much medication people still have in the bottles. Time consuming, requires research staff. You know, what you're relying on is if there's missed pills, you're assuming that they're taking it and not just not showing you the pills. What Robert will cover more extensively is electronic monitoring, which is sort of a newer space that we are doing in terms of pharmacoepidemiologists, where we're we'll come back to this, but we're measuring electronically how patients are actually taking medications based on their pill bottles, for example. And then this last one is the one that I will spend most of the time covering, which is how can we measure adherence using dispensing data or administrative claims data? And so, we'll come back to really the advantages and disadvantages, of course. But the biggest thing really is that we're assuming how patients are taking medication based on effectively their refill patterns and how they are filling in the dispensing data that we're looking at. So it gets challenging when doses are changed, when medications are switched, when medications are added, some of the multiple medication stuff Robert was talking about. And ultimately, we're assuming that if you filled the medication and you got it dispensed to you, that you are taking it. And so that is why we still have a space where we're doing a lot of these subjective measures, because there's granularity that is often lost when we're relying on how often patients are filling. Cool. All right. So what do we do in terms of adherence from our dispensing data? So when I mean dispensing data, I mean typically two ideas. One is claims data from insurers, which is the most common, data that we talk about here at ISPE. I mean, like databases internationally, databases like in the US, like Medicare, Medicaid, for example, any variety of claims data. I also mean sometimes, with different caveats that we probably won't be able to get into today, retail transaction data, sometimes from pharmacies directly. Say, for example, you can actually work with a pharmacy and get their transactional data as opposed to relying on the insurer data. There's different trade-offs, but the whole idea is basically that you're getting sort of these refill patterns, regardless of what the exact setting is. And so you're measuring adherence based on these patterns. And so the first question I get asked often is like, really, what's in dispensing data? And I'm sure many of you are familiar a bit with what lives in these claims data from the medication side that we're interested in. But I think it's important to point out, and the question I always get when I'm doing a research study is, okay, what level are you measuring your medications at? And so I think it's important to point out that in the US, we're usually relying on what the medication is from like the National Drug Code or the NDC, which captures different elements about what medication was dispensed. And for our purposes, we typically don't care about the manufacturer. We're really just trying to measure the generic name of the drug. And that is really kind of the key that we're really keying on for adherence work. Internationally, we often have GPI or generic product identifier, which is a little bit better. And if you take a drug utilization course here, you'll learn a lot more about it. But basically, it's a same kind of hierarchical system that we're using ultimately to try to just measure the generic name. We're really ultimately interested in the actual name of the med. And so when we're doing all these adherence studies, we're working with these more granular identifiers like the NDC or the GPI, but ultimately we're interested in the generic name. Okay. So before I get into how we measure adherence using these data, there's a few things I want to point out that are relevant to other areas of pharmacoepidemiology, but are really relevant for adherence research in terms of the data that we have and what data we don't have. So what I mean by that is, if you're doing an adherence study, you obviously won't have information on over-the-counter medications, right? It's prescription data. We are relying on fill data. And so it has to be a prescription. And so anything that's over the counter would obviously be missed. And so for some disease states that matters, for other that's not as relevant. We also, and this is really relevant for the US in particular, any medications that are really dispensed outside of the insurer or say outside of the pharmacy, depending on what data you're working in, we won't have and we won't know, and we would likely be missing that, but we won't know. And so the patient would be thought to be non-adherent. There's kind of two key examples of this. One is like prescription samples for say brand medications or new medications. Patients will often be given samples like, hey, try this, see if this works for you for a month or two. And there was a study that was done a couple years ago, kind of looking at how often that happened. And even in the branded statin space, 1 in 7 patients in the US had evidence of having a sample and were otherwise like we were not capturing new use correctly. And similarly, patients filling outside their insurance benefits, say it's cheaper for them to pay cash or pay out of pocket. In the dispensing day that we're working in for adherence, we would not have those data. And so those patients would typically be classified as non-adherent, or we'd just be missing their fills without knowing that they filled outside their insurance benefit. So this is when I review studies, particularly in the US, this is one of the things that always pops out to me is, do I know that there's a lot of situations in which the patients wouldn't be filling through their insurance? And so things like relatively all these GoodRx programs, different types of programs here in the US, we would not be capturing them. So it's relevant for adherence. Maybe it doesn't matter because it's sort of equal across the study sample we're looking in, but something to consider. Okay. So now the fun part, how do we actually calculate adherence? Well, we'll come back to this, but we're still thinking in terms of the constructs that Robert introduced us to. The 3 real constructs of adherence. So there's the initiation phase, like whether patients start the drug or not. There's the implementation phase, sort of how are patients taking the medication in the window we're interested in. And then there's the persistence phase, which is how long do people continue to take the drug? And so leaving aside the initiation phase for a bit, which Robert was getting into briefly about how we need kind of different types of data to really know whether patients were supposed to start the drug or not. For really the more common ones we do in pharmacoepidemiology, these implementation and persistence phases, from the dispensing or claims data that we're working in, we typically need 3 things. We need the drug, what drug they're taking based on like NDC or GPI that we were talking about. Sometimes dose, depending on if intensification is important to us. Then we have the dates that patients were filling the drug, and we're bringing those and concatenating those together. And then we also, in order to know how relevant the dates are, we need to know for those dispensed medications, what was the day supply that those were supposed to be taken? Were they supposed to be for 30 days? Were they supposed to be for 60 days, 90 days? And so that's generally coded at the time a pharmacist is filling the prescription in terms of what the day supply is intended to be, and then the quantity that they received. And so we're stringing all that together, and I'll show you how that looks. But that's ultimately the 3 data points that we need to measure adherence. Okay, so before we kind of march any further, like why we talk about, I'm going to talk a lot about disadvantages of claims data. I already introduced you to them. And so if you learn nothing else, it's the critical thinking about the data source that I'm working in, and whether it's good for you to measure adherence or not, or any other pharmacopy study you're doing. So what's good about these big data, I hate that word, but these larger data for adherence is that they're large, right? And so that's useful to us typically for a variety of reasons. More importantly, because they're prescription data, if they were paid for by the insurer, we're going to be seeing them. And so unless we're worried about patients filling outside the insurer, we're going to have any medications in our data that were tied to them paying for it. We have all the prescription medications, dispensings, and what's really useful is knowing enrollment. So of course, when you are using claims data from an insurer, you know when they were no longer enrolled. That's just the function of the data that you're working in. So it helps you for adherence measures to know whether you were supposed to be able to measure adherence for a patient over the course of a year, because you would know that they were continuing to be enrolled. So there's some usefulness from there. But of course, for the dispensing data we're typically working in, say claims, we're focused on insured patients. Sometimes if we're working in interventions, the process for claims being considered complete, as anyone knows, you're not immediately getting claims like the day after they're dispensed. You're usually getting them a year or two later, right? Or in our case, sometimes months later. And so there's this lag that happens for claims to be considered complete and fully adjudicated by the insurer. And so it's not just, your ability to get the data quickly, it's also their ability to consider it complete. And so if you're trying to react to, say, new medications or identify patients who are non-adherent for an intervention and reach out to them immediately, this lag can have some real implications. And so really, from pharmacoepi, of course, like missing dispensations is really critical. And then lastly, the fact that in these data, refills are typically 30 or 90 days for chronic medications in particular. The fact that these are intervals makes it such difficult to look at things over the short term, and that we're typically looking at things for adherence for 6 months or 9 months. And so kind of comparing the different data, kind of the most important thing to think about with these dispensing data compared with other things that we'll make sure these slides are posted after if you want to spend more time thinking about it, is that typically, there's lots of patients in these studies. The cost to obtaining these data is like relatively moderate, but we do not know whether they for sure took the drug, right? We know that they were dispensed the drug. And we're not continuously measuring how people are taking the drug. So this contrasts with what Robert will present in the next section, which is allowing us to get at that granularity. Okay, any big questions so far? All right, I have eyeballs, so I think we're okay. All right, so now we're good. Oh yeah, please. I think I heard her question. Yeah. So GoodRx was. No. Yeah. So yeah. I'll repeat the question for everyone. So it's kind of a US thing, again, because prescription drug costs are a key thing we think about here in the US. But there's different prescription drug programs that are not insurance that people can sometimes use to get medication. And so one example I gave was GoodRx, and I said it really quickly, but basically it's an online program where people can go and see what the cash price that without insurance price would be, and they can take that to a pharmacy and get it filled that way. So they're kind of a new pharmacy insurer middleman. They're just not the insurer. So the point is that those data would exist at the pharmacy, say CVS, but they wouldn't exist to the insurer because that information was never passed to, say, Medicare or the insurer. You're not supposed to use it with Medicare, but that's besides the point. And so those data are not always linked. And so that's something that I find really fascinating, because where we sit is kind of the juncture of policy and EPI. And one of the things I find most fascinating is the fact that we're trying to give people more options to get drugs, but we're reducing our ability to sort of do the surveillance that we need to see adherence and safety and other things. And so I don't think that's always recognized as well as it is. So I'm going on my soapbox here for a second. Yeah. Yeah, so the question was about like the prevalence of filling for cash versus, say, other medications. There have been some studies, they're hard to do because of this requiring different data sources, because you would need the pharmacy and the insurer and a variety of ways to do it. We did a study already 10 years ago, gosh, that was in warfarin the space of anticoagulation, trying to figure out patients who were getting regular lab monitoring. And so they were getting the drug because they were getting this very specific lab monitoring test, but we weren't seeing the presence of the drug. And it was about 10% of the sample. And I expect that that's higher now with more programs, and especially for more expensive drugs. So the answer is, I think there's going to be really, really good studies kind of thinking more about these new prescription programs, especially even the Mark Cuban cost plus drugs has the same problem. It's not going to be linked with insurer data. So I think there's going to be really cool studies that are looking at this coming out. We just don't know yet. Great questions. Okay. So how do we measure adherence? So as a reminder, we have our taxonomy of adherence. And basically, in a perfect world, the clinician writes the prescription, patient fills it, patient continues to take it, et cetera. And so our first phase is initiation. And it's, whether patients start the drug. Then we have our implementation phase, which Robert was getting at, which is, do they delay, omit, take extra doses? We have our persistence phase, which is really about whether patients continue to take it or don't discontinue. So how do we measure initiation? This is the one I see in my pet peeve in terms of reviewing papers. Most often poorly described or poorly done, to be honest. Because I see a lot of times people relying on just the pharmacy dispensing data to describe whether patients started drugs or not, or whether patients were prescribed the drug. But in the dispensing data, we only get the fills that patients actually had. And so there's a funnel of what was prescribed but patients couldn't afford or decided not to take that we are just missing. And so really, to do initiation, we need both data sources. We need to know what was prescribed / what was intended and what patients actually did. So between those two things, we actually know what patients started. And so really kind of the best way to do this is electronic health record data from prescribing linked with claims data or some sort of source. And so there's problems with this, like what's truly initiating, whether medications are adjusted over time, what's the rate, what's initiated, like what's the window? Does it have to be the next day? Could it be a month later? But it analytically is not as challenging as it probably seems. Basically, you're looking for the prescription and you've set a definition about when I should be seeing that refill or that fill. And so you're saying, okay, do I see that fill within the window that I defined after the prescription was written? Yes or no. Sometimes it's time until, but effectively it's what you're doing. So here's an example. So there was a study, now several studies done on this, linking electronic prescriptions from US providers with insurer claims data. So you're kind of linking what was on what was actually filled and reimbursed. And so the investigators classified a medication as initiated if it was filled on or after the date the prescription was written. And so they defined here rates of initiation as number of prescription filled over the number written. And what blows my mind, it continues to blow my mind, is for any of these studies I see, even for chronic medications, roughly 20 to 30% of prescriptions that are written are not filled for a variety of reasons. That's why my pet peeve of patients were prescribed X number of medications when they don't actually have the prescription data and they're relying only on claims is I think justifiable, because the funnel is actually starting, if you're really looking at what physicians intended, 20 to 30% higher. And this is still the case. The study's from like 10 years ago, but this is still the case for a study that we did recently. And so it's basically what you're saying is that among those who did not fill, so the actual initiation rates were 70%. And so this example just covers hypertension, diabetes, gynecologic medications, just to kind of give a flavor of what this looks like. And so you could do, in this case, they did any time after the prescription was written. Most of the time we say, okay, within 30 days. And from a pharmacy context in the US, we usually we'll put a medication back on the shelf after 2 weeks. Because it's usually, that's the level of insurance window that's for pickup. Anyway, so about 30 days is probably the most common one. Okay, so more fun, the implementation phase. And so when you see adherence or think about adherence in literature, this is usually what's being measured. So this is, again, filling, emitting, taking dextrodoses. So how do we do this? So I talked a little bit about, you have the medication names, you have the dates, the dates medications were filled, you have what the actual medication supply, day supply was supposed to be, how many days that prescription was supposed to cover. So we use those and create what I like to call a supply diary. Effectively, you're creating a diary of the medication fills for each patient, starting with the date that you're, say your index date and when the patient started the medication, and stringing those prescriptions along for as long as you've defined in your study is important. So say, for example, 6 months to a year usually. So you're taking those fills. Here's an example of one patient where you have 4 prescription fills for them. The first 3 were 30 days. They were intended for a month. And then the last one was filled for 60 days or written for 2 months. But of course, when we're thinking about our supply diary and making sure we're giving patients credit for how much medication they're taking, patients don't perfectly show up every 30 days and get their prescription filled. There's a variety of reasons why sometimes people go early. For example, maybe they're going on vacation. Maybe it's just less convenient for them to come perfectly on day 30. So there's always an overlap, almost always, that we have to account for. And so basically we have several data processing steps we take into account where we're fixing the overlapping prescriptions and other things about the measurement period that we're interested in. So effectively we go shoop and we set it so that the next prescription of prescription 3 is actually sitting right after prescription 2, even though there was an overlapping and filling, because we assume that patients aren't taking 2 doses on the days that there was an overlap. We know that they're waiting to start taking their next one. So that's just an example of some data processing we do. And so in English, we usually, when we write a protocol, we say create a supply diary by linking all observed fills of a medication based on these dates and day supply from the index date or the date that we're most interested in starting until the end of the study period. Other processing steps that are really important to consider for your study, in addition to the overlapping, we'll come back to this, but say patients switch medication or like there's 2 different medications for blood pressure that they start on one, but then we see another one. Do we consider those separately? Do we think they switched? So we often have to just make a choice that we're going to apply equally to everybody in the data. And so we'll say, okay, if they filled another blood pressure medication, we're going to consider it interchangeable. So if someone started on atenolol and they moved to metoprolol, we're going to say, okay, they're not taking both of those at the same time. Add those together in the supply diary, consider them one long string. So there's just different processing steps you need to apply in order to really think about whether you're measuring adherence appropriately. Then there's this overlap I was kind of getting into on the prior slide. At a certain point, we say, okay, that's enough overlap. There's something about you. And so we often say, okay, accumulate up to 90 days of overlap, just to not be overly, conservative. So there's different ways of approaching it. The other thing that often comes up when we write papers like this is, okay, the patient was hospitalized. They weren't using their home medication typically. They're usually using medication from the hospital. So how do we account for that? So typically we just say, okay, they were hospitalized. We know the dates they were hospitalized from the other medical claims data we're working in. Not always the case. And we say, okay, we'll insert that 7 days and just shift their supply diary after that, because we assume that they were covered with medication while they were hospitalized. So there's just different processing steps that before we even go about the fun of creating our calculations and our measurement, setting this up is really important. Okay. So now that we get into the fun, okay, so say typically as adherence researchers, we're interested in measuring adherence as an outcome. So say, for example, the relationship between like race and ethnicity and adherence as an outcome. So that's the way that we might set this sort of study up. When we do it that way, there's a couple of considerations that, again, when we're doing this processing, we have to think about. And so a lot of times when we're defining our cohort for an adherence study like this, we have to think, okay, are we interested in brand new users to a medication? If so, then we start on an index state, but how far back do we assume that they are brand new users? How far back do we look to define them as new use? And so for adherence, I typically do at least a year to assume that they weren't taking medication before, or kind of any prior time that I have. Maybe sometimes we are interested in prevalent users because those are the bulk of people taking chronic medication, or those who were previously taking it. And so in that case, where do we start the index date? Any supplies, medications that were filled beforehand, how do we handle those? Typically, we sort of allow those to be counted if they've overlapped with the index state, but there's small things you kind of have to consider there. When is follow-up done? This is kind of germane to any type of study that you're doing, but is it the end of a year, 6 months, et cetera? Usually we do at least a year, but you could do like a smaller period of time. And then the fun part is, how do you summarize this? Come back to this. How do you actually use the supply diary that you've created to sort of summarize what adherence is? And, is it continuous? Is it categorical? How do you do this? And so you have to make some decisions around that. Usually I like to keep things as a continuous variable as much as possible. But sometimes categorical makes sense if you want to define people as adherent or non-adherent specifically. Okay, so how do you do this? The most common one now, I would say, is the proportion of days covered metric, or the PDC. And I say that with some acknowledgement that European colleagues typically like a different measure, but in the US, this is the one that's the standard. But the point is, even if it's medication possession ratio, which is the most similar one to this, or the proportion of days covered, the way you go about setting things up and calculating things is approximately similar. And there's been enough studies to show that regardless of how you summarize it, whether you use proportion of days covered or medication possession ratio, it really doesn't make that much of a difference when we relate it to clinical outcomes. They're only slightly different in the way that you summarize them. So pick your favorite. I like PDC. I think it's easy to think about. And so take, for example, 2 patients. Patient 1 has these 3 90-day fills at the top. Patient 2 has these 7 30-day fills. And proportion of days covered is effectively kind of what it sounds. It's the proportion of days or percentage of days in the window of follow-up that patients have medication covered after we've done our pre-processing and deal with the overlap and deal with the hospitalizations, et cetera. So for patient 1, as best as you can tell, what do you think the proportion of days covered would be? So I'll walk you through this. We have, assuming the second fill that I've kind of made overlap, we shift that. We have 3 90-day fills out of a 365-day period, even though I didn't make it look perfectly like that. So that would be 90, 90, 90 divided by 365. That's really kind of what the proportion of days covered is for this patient. So their proportion of days covered is 74% or 0.74. We'll come back to what that means. Like, is that good or bad? So with that in mind, what's the PDC or proportion of days covered for patient 2? Patient 2 has 7 30-day fills. Anyone want to take a guess? Elise, can I put you on the spot? Yes. Yeah, perfect. Exactly. You're right, Heidi. Thank you. So I say you're right because I didn't tell you that there's this last like 5-day bit that we are ignoring because it's after the 365 days. So it's 30, 30, 30, 30, 30, 25. By 365 is 56%. Nice work. Thank you for volunteering. I appreciate you. Okay. So that's basically how it looks. And we're doing this at scale for all of the patients. So we're summing the supplies, dealing with overlap, allowing for switching, et cetera. So that's really what this is. Cool. And the similar kind of idea among prevalent users, we had a nice new user case example here where we're allowing for overlap. And we're basically doing the same sort of calculation, just allowing for what they filled before to count. And so for patient 1, they would be allowed this extra piece that's sort of filling over. Okay. So let's take an example of a patient to try to talk through some other situations when we're measuring adherence that matter. And so Ms. C takes a couple of different medications for cardiometabolic disease, high cholesterol, 2 for diabetes, and 2 for high blood pressure. She's a very real patient. And so when we are thinking about medications that she's taking and how, this example we talked through assumes one medication, not assuming that she's a complicated patient that has multiple medications that we may be interested in knowing how she's taking them. Across her 5 medications, maybe we're interested in adherence to all of them. Maybe we're interested in just the disease state, maybe the class of medication that she's taking, maybe each drug. Typically, I would say class or disease is what most people are doing adherence calculations on. So once you get to the patient level, you have to make more decisions about what's a chronic medication, whether people are really taking them for a longer term. But nevertheless, you have to kind of make a decision about what you're interested in. And so as part of that, if it, like Ms. C, you're taking multiple medications, when you're doing this supply diary calculation, if I'm interested only in, for example, adherence to just one medication, Ms. C has 3 different fills, but for diabetes, but her medications switch. So glipizide to glyburide to pioglitazone. So if I'm interested in just measuring adherence to glipizide, she's pretty poorly adherent because she's only filled for 90 days out of the whole 270 here. But if I'm saying, okay, I want her to allow at the class level. So any sulfonylurea is fine. Okay, well, glipizide and glyburide are both sulfonylurea medications. So, okay, now her adherence is actually 60 days or whatever this, is much longer. It's like 2/3 of the entire window. But if I say, okay, as long as she's covered with diabetes medication, period, what does that look like? Well, then she's actually fully adherent the entire time. And I would say this is also something that if you do adherence work, this comes up a lot. Is it, coverage of any medication, regardless of whether you're supposed to be taking multiple medications? And insurers and other policymakers, they often take this at least one medication sort of approach. They say, if you're on diabetes medication, okay, great. But I think that's kind of an overgeneralization and really interesting to get at the nuances of multiple medications. So a lot of times we'll average them across what patients are doing. Okay, so now what is adherent? And so I gave you these 2 examples. One patient was 74% adherent, the other patient 56. What is good? Well, good depends on the disease state you're working in. Robert works mostly in HIV. He's always saying like near perfect adherence is really what you need. I work in a space where it's more cardiometabolic, the examples I've been giving. And so historically, a lot of the work that we've done to sort of relate what is good adherence and clinical outcomes kind of comes more from the cardiometabolic space. And historically, we've thought that about 80% adherent is ideal. So at least 80%, which feels lower to me than what I think it should be. Of course, people should be perfectly adherent. We know that's not always the case. But there's been different work that's really kind of shown across different thresholds that if people are covered with at least 80% of their days of medication, they do see clinical benefit in terms of lower cardiovascular events, for example. And so this slide is really just kind of showing you that among patients who are fully adherent, this red line defined as this 80% or more, they see this lower rate of bad outcomes compared with even those who are 60 to 80% who look virtually the same as those who are less than 60% of the time. So not perfect. This is a huge source of debate. And people who spend a lot of time thinking about this is like, what is good adherence? Which is why I often try to stick at least first with the continuous measure, what their actual adherence was and looking at changes, because I'm not making assumptions about what should be good or bad. Okay. So now, if you're not an adherence researcher, you're not really interested in looking at adherence as your outcome, how do you think about it in terms of like it being an exposure for your study or a covariate or confounder or something else that you're interested in? So this, when people come to me a lot, this is what they're really interested in, is saying, I'm interested in sort of looking at the effectiveness of drug. How do I account for their adherence? And so we have a couple of different patients with different filling. In this case, it's an exposure. So say, what's the relationship between optimal adherence and long-term cardiovascular benefit? Like if you're going to set this up as your association. So you would take, how would you calculate this? You would take your index date for your clinical outcome typically, and then look backwards for what patient's adherence would be. So there's several things you have to think about there. You're still using, say, proportion of days covered to measure that window. But what's your window? Do you look back a year? Do you look back 6 months? You know, usually somewhere between 6 months to a year, and you're creating the same calculation that's happening at baseline as with the outcome. But you need to make a couple other decisions. You have to think about the window. Is it, again, continuous or binary? But typically, I suggest starting with the first date of the fill in that window. So not taking the whole year. So not assuming that the patient should have had medication here. Maybe they hadn't started it yet. So I start with the first fill, looking backwards for each patient, and then measure their adherence starting from there. And so similarly, with measuring it not as an exposure, but say as a covariate, we kind of take the same approach. We start looking at the first fill that happened in that window, and then looking forward. But there's things that always come up when we're thinking about using it as a covariate. Probably the most important one is, what if patients don't have any fills at baseline? We shouldn't classify them as non-adherent per se, because maybe they weren't supposed to be on that medication yet. And so there's a couple of things we will often consider. Number one is maybe we'll take adherence to any medication rather than, say, just a smaller set of cardiovascular drugs. Require patients to have filled at least one medication at baseline, and then we measure their adherence to that. Or maybe we say, did they use a medication? And then measure their adherence if they had a medication and treat that as an interaction term. Sometimes we'll do that. So anyway, there's a variety of things you might think about, but probably key number one is, if you're thinking about using adherence as a covariate, either you need to condition on everyone having filled that medication that you're interested in measuring adherence on, condition on another medication and allowing all of those to be calculated, or maybe even treat as missing, but at least don't treat them as non-adherent if they're not supposed to be taking a medication. Yeah. Yeah, you can do that. You can account. Yeah, so the question is, do you often account for the date that they started? So say, you know, there's patient 2, you're starting almost near to the year, and then patient 1, you're starting at 10 months. Yeah, you can account for that. It is basically as a covariate too. Sometimes we'll say, okay, they at least filled 6 months prior. So we have at least 6 months of information on everybody. Cool. Great question. Okay. And then the other thing people are often interested in is, how do I know what the effective adherence was in my study? So there's a variety of different ways you could do this. Some are good, some are bad, some are emerging methods. The first one that I see still, unfortunately, too commonly is that people try to measure, say, adherence and their outcome in the exact same window. So say, I'm going to measure adherence over a year and also measure my clinical outcome, that is my outcome, in the same window. So there could be reverse causation issues with this, right? People may be adherently different because they had a myocardial infarction. That is your outcome that you're measuring adherence after. So there's very weird reverse causation issues that are related to that. Do not recommend. At least a safer approach is to treat the two windows separately. So adherence and then outcome. But depending on how long your adherence window is and your outcome window is, so say you're measuring adherence over a year, then you reset your index date and you're measuring your outcome. It starts to get very long from when what if adherence was different early in the 1 year window that you're measuring compared with later in the year and how that relates to clinical outcomes. So at least this is a clean epidemiologic approach, but it could set you up for maybe kind of missing some nuance in terms of the relationship between adherence and outcomes that you're interested in. But I'd say at least this is safe, which is nice. But kind of increasingly, there's kind of other ways that we can think about this. And so, we can use this. And so, so rather than adjusting, I got this out of order, sorry. Rather than adjusting for adherence, we can measure it as baseline and account for it. The other thing that we'll do in comparative effectiveness studies is that for as treated analyses, we'll censor when patients reach a certain day supply gap. This will feel like persistence. And so that's kind of safe too, because we're censoring patients when we're measuring the outcome. And basically kind of the other idea here is that when you're adjusting for adherence in studies of safety and effectiveness, you do need to be careful about when you're adjusting for things. Because again, if you're measuring things in the same outcome window, it could be a problem. So that's why I think censoring usually makes sense a lot. It's just when people stop taking the drug, if you're interested in as treated analysis, at least that's safe that way. But what I was really trying to start getting at was if you're really interested in modeling the relationship between adherence and clinical outcomes, like say it's not just a nuisance, it's not something you're just trying to adjust for, but you're really trying to get the relationship. There's ways of treating adherence really as a time varying exposure. And so without getting too detailed, there's ways of setting up smaller pots of adherence over time. So say monthly, for example, and then measuring outcomes the month after that, using the way you set that up as marginal structural models effectively, where over time you're measuring more cleanly smaller discrete units of adherence and outcome rather than say the long 1 year before and 1 year after. So without getting too super into it, if this is what you're really interested in, there's more advanced methods to be able to think about that relationship and how you would measure it. Yeah, please. Yeah, so the question is, how would these kind of, say, time varying exposure approaches compare with the as treated approaches? I think as treated, to me, I confused this and I said it kind of confusingly, but the as treated approach I see really as more of an example of how we do adherence work in comparative effectiveness studies, because we'll often censor people when they stop taking a drug. And so that's relating and similar to this idea of persistence, which we'll come into, which is people stop taking the drug. How often does that happen? And so typically, I wouldn't say that as treated analyses are directly comparable to time varying exposure analyses. I think what is maybe a fairer comparison is the time varying exposure analyses with the longer windows. And I'd say that you typically see kind of stronger magnitudes of effect using the marginal structural model approaches, the time varying approaches, rather than the sort of the long periods, because you're just kind of washing out the effect a little bit more. Sorry, I made that confusing. Okay, so now since I kind of introduced persistence and haven't really talked about how you measure it, the last thing is persistence. And so persistence is this: do patients continue to take the drug or not? We use it and set it up actually almost the exact same way as implementation. So you're basically setting up your supply diary in the same way that you did for implementation, but now you're measuring something else about it. And so we have typically kind of two methods that we use to see whether patients continue to take the drug or not. There's this refill gap method or gap in day supply, which is going to sound similar to the as treated approach I just talked about, where you've censoring people for comparative effectiveness studies after they stop taking the drug. And then there's a treatment anniversary approach, and I'll kind of walk through both of those. The first one is the refill gap method, where basically you're looking at fills and you're looking to see where is there a sufficient gap that patients stop taking drug. And what is it? What is the rate gap? And so this is always the question that we have. And so sometimes it's a 30-day gap is considered they stop taking the drug, 60 days, 90 days. Those are probably the most common ones. But you're effectively looking in your supplied area until you see that gap. And then you're considering them non-persistent or censoring them for your studies. Whereby the treatment anniversary approach, I kind of like, even though it's less common, because I think it's sort of intuitive. Otherwise, this is like, they stopped taking the drug for at least 30 days. There's something weird about how to describe that to people. But I think there's something kind of nice in explaining to people. 1 year later after starting, 50% of people stop taking the drug. Because a treatment anniversary approach is kind of like a wedding anniversary or an engagement anniversary, where you're looking from the date that you're starting follow-up until 12 months later, for example, where you're seeing, is there a fill that overlaps with that window? In which case, they're still taking the drug or not. There's disadvantages, of course. You're missing and you're not taking into account what's happening in the interim. But at least from a how you explain whether this matters to other people perspective, there's something kind of nice and clean about saying only 60% of patients are still taking drug 1 year later. That's why I kind of like both approaches. So how do we measure this? Okay, so persistence, we set this up the same way, exact same patient 1 and 2. Rather than calculate proportion days covered, now we're calculating persistence. So if we're taking the refill gap method, saying a 90-day gap is what I consider to be non-persistent. They stop taking the drug. For patient 1, are they persistent or non-persistent, assuming a 90-day gap? Who says persistent? Yeah, hash marks are 30 days. Thank you for clarifying that. Who says persistent? Who says non-persistent? Great. Okay, so we're all on the same page. So that patient is classified as persistent because we needed 90 days in order to determine that they were non-persistent. How about patient 2? I just realized I gave you the answer on this slide. That's okay. Yeah, so patient 2 is non-persistent, right? Because at the time that they stop filling, you see a 90-day gap here. They are no longer persistent. And so the treatment anniversary kind of is a similar flavor. Patient 1 is the opposite in this case, right? So patient 1, if you use a treatment anniversary, you're looking a year out and you're saying, oh, actually they stopped taking drug. But weirdly enough, patient 2, they have a refill that overlaps with 12 months. And so we're still saying they're persistent. So that's why I think each method has kind of its strengths and weaknesses. And I like thinking about both when I do these types of studies. Great. So here's just one example of the treatment anniversary approach using a database in Quebec, where effectively they identified treatments that were initiated and then looked 30 days, a year later to see whether there was a refill within that time period. And so what they found, and this kind of tracks with what I typically see, is that persistence rates were about 80%. About 80% of patients were still taking drug. It very much depends on the disease state, of course. I see Robert nodding. But sometimes we see persistence rates of like 90% or more for some drugs and some diseases. And sometimes it's closer to 40%. I'd say there's a lot of variability typically when thinking about persistence. Okay. So difficulties here are slightly different actually from implementation, which is when patients stop taking the drug, again, without knowing what was ordered or prescribed by physicians, for example, we don't know if the clinician wanted them to stop taking the drug or the patient just stopped taking the drug. So there's some assumptions that go into play when thinking about discontinuation. So we always have to be careful if we don't have what was prescribed. And similarly, like implementation, you have to think about if we saw switching across, say, diabetes medications, did they stop it or did they just add on a drug? Like, what does that mean? We have to make some decisions about that. Okay. And so just to kind of level set again, for this dispensing data we're typically using alone, compared with other data sources, we do not know without prescribing data whether patients, we could truly measure initiation or not. We know whether patients started, but we don't know whether what was actually intended. And we're missing that 20 to 30% of the funnel. But we can measure implementation and persistence quite well. Okay. Questions? Oh, okay.
So you mentioned that you favor using continuous. So when you analyze, so you've
Yeah.
summarized their adherence, you give everybody's got a number, and let's say it's a percent from 0 to 100, assuming no over adherence.
True.
They're between 0 and 100 for the amount of med they've taken. And you prefer to compare people on a continuous scale of and so what you get out of your analyses is the an individual percent number that matters related to outcome.
Yes.
Okay. So how do you and you don't favor thresholds, because comparing somebody who's 81% adherent and saying, well, they're great, but a person who's 79% adherent, they're terrible. So
Yeah.
you don't favor that because that threshold is too stark.
Yeah, I think it's too arbitrary
So
usually.
my challenge there, and I think I have a solution that I want to offer up, but
Great.
the challenge there is, how do you handle 5%? How do you handle 10% difference? So your person who went from 73%, which you worrying about them, got to 83, went up to 83%. You're starting to feel good about them. There's your person who went from 11% to 21%. You still feel it was horribly terrible, and it's still horribly terrible. And that, who cared about that 10%? It mattered almost not at all.
Yeah.
So do you want to offer a solution or
I'm happy to hear yours, but to me, that's why I often do both. Like I often do both dichotomous and continuous, because it's getting at kind of both of those situations. And what I will often do is look at different subgroups of kind of who moved, and thinking about, is it 10% relative at the lower scale, or is it the upper scale, and kind of thinking about that a little bit more deeply.
Yeah. Anybody want to offer other potential solutions that they might have thought of?
Yeah. Yeah. Also that, yeah. So you can look at different cutoffs and sort of determine what cut points matter to you. We'll do this a fair amount too. A lot of times we'll look at maybe say quantile changes sometimes, like thinking about, did people move from different quantiles in the data, and thinking like it's not just the one threshold, there's kind of multiple thresholds. Yeah.
Yeah. So to expand on that, I think it may also depend on the drug and the disease. And so what I've tried to do in the past is use not just quantiles, but come up with clinically relevant amounts, especially if people have done threshold studies in the past, and you get a sense that, you start to see, well, if you take up to 60% of your medication, you're still not going to have success. And then between 60 and 70, a certain proportion of people will be successful. From 70 to 80 more, 80 to 90, 90 to 95, et cetera. And so what I've done in the past is used those categories and then see if people are transitioning from one category to the next, or from one category to multiple categories above. So comparing people who've gone from, 10 to 20% isn't going to change anything, and they're still in the worst category, and it's as if they've had no effect. Whereas people who've gone from 75 to 85 now have crossed the threshold, and they may have had a benefit. So it's, again, all of these decisions, and I think we sound a little wishy-washy, is that we're not telling you definitively, okay, measure it this way, do it this way, establish it this way, because it's going to depend on the drug and the disease relationship. Each of these decisions is going to be specific to your individual study, including your question about which is better. I think it was your question about which is better, the time, actually it was in the back, the time series measure. It's going to depend again on the drug disease relationship, because if the drug adherence now matters for 5 years from now, it's not really going to be very relevant to keep measuring adherence in the last 30 days and then did the outcome occur, adherence, did the outcome, adherence, outcome. You may need a longer period of time. So it's going to vary by the question that you're trying to answer, and that depends on the drug and the disease.
Yeah. I think there's two other small, I know we're spending a little more time on this, but you've had great questions, so I'd rather do that. There's two more things I'll offer up that often seem related to doing this type of work. Number one is, while I favor continuous measures, adherence, and this always comes up with any new student I work with, they're like, but the standard deviations are terrible. It's not a continuous outcome. And it's true. It's just, there's different ways we can do it. We can kind of look at the medians and compare the medians. Of course, there's different approaches that you can do. I still kind of like, from an interpretability standpoint, still starting with the continuous. It's exactly why we do these different thresholds, is because adherence is not normally distributed. You will find that out immediately. Part of that is because we're constraining the threshold from 0 to 100. And so part of it is that kind of reducing our ability to see a normal distribution. Kind of the other thing is just there's lots of weird skewing and things that happen in the data. So it's something else to consider, is we know that it's imperfect. And so a lot of times we have a bunch of different robustness analyses that we'll end up doing, trying it different ways. The other thing I'll offer is that, we do get excited kind of when we see from a continuous standpoint, say a 5% difference in adherence from something, because different studies have kind of shown that it's imperfect along the scale of where people are starting from, but a 5% average difference in adherence is shown to be related typically with an improvement in clinical outcomes. So if you're kind of explaining why this matters, because adherence can be sort of thought of as a proxy outcome for the clinical outcome that we're interested in, a 5% difference is something that's generally exciting, for lack of a better word. Okay, yeah, great question. Interesting, yeah. When you say reimbursement, what do you mean exactly? Can you give an example? Yep. Yep. Yeah. Okay. So the question was in the US. Thank you for, it's a good question. The question was in the US. A lot of times there's actually reimbursement to insurers and payers and even providers sort of tied to how adherent their population is. So that's why there's kind of different ways that people will game the system a little bit in order to improve their adherence in the population that you're doing. A couple of those I sort of half mentioned already. Number one is longer dispensations. If you send people 90 days a pill, they're going to be adherent for 90 days a pill. And so you might have to, if you're an objective consumer trying to measure adherence, you obviously would want a longer time window or sort of accounting for that. The other one I see most commonly is this idea of, did they have at least one medication for diabetes? Versus they're actually supposed to be taking multi-drug regimens, but the way in which we are measuring and calculating adherence, most of the time for those payer calculations, they're allowing and considering patients to be adherent if they just have one drug covered. And so that's kind of how there's small ways that this, I shouldn't say it like this, but the system is kind of gamed in terms of kind of improving overall average adherence. But the thing is, if you're kind of looking at differences or changes from an intervention, a lot of times that at least ends up being non-differential if you're working with the population. But if you're trying to get sort of average rates in your population, those types of things become really relevant. There's probably more examples, but those two jump to mind.
There's something going on that's related to utilization of drugs, measurement of the outcome. What's bothering? There's something sticking in your craw that's bothering you about it. What's bothering you about it? That'll help you identify what the change in the design to try to minimize the impact. I'm not getting conceptualize how it's going to impact it, and I suspect you're right that it will increase the bias. But maybe if you can more specifically formulate the question of what is how is reimbursement been affected. I think we do that. So please comment.
Thank you. Actually, I'm doing the daily work as she asked her question. So we're the one of the largest insurance company in the US. We do the medications adherence separately for commercial, Medicare, Medicaid. The question she asked about the Medicare adherence. So, you know, CDC has a star rating.
Sorry.
So like Dr. Lauffenberg said, so actually there are so many reimbursement, reimburse CVS, reimburse patient, reimburse provider, reimburse, even you have like a 4 stars, the government reimburse you. Yeah, if you have lower stars, 1 or 2, government will punish you. Kind of also for the medication, for the Medicare, for the low income, we say, okay, we give you medication for free. That's another way to reimburse members. So like Dr. Linder said, like, you know, for example, if I decide to give them for free, give them as a mail order, I ship the medication. It doesn't matter if they take it, we don't know. We are not able to measure. However, I propose, I said, well, if we don't have the measurement for the medication adherence, then we measure their A1.
Oh yeah, the A1C
For the diabetes. Yeah. So we continue to measure them. If they don't have a good effective, then that means they may not take the medication or something.
But what you're pointing out, and I know you're proponent of the percentage-based coverage.
Yeah,
So
PPC.
what that would be biased, because if I
Yeah.
want to get reimbursed, I'm going to ship the medication.
Exactly.
as frequently
100%.
as much as I want.
Yeah.
And so the counter to that, and Julie and I fight over this, but you know, we look friendly, but it's very, 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 you know, a lot of animus over this. Is I prefer the percentage-based coverage, which requires the medication prevention ratio, which requires the next bill to occur in order to show that the days were that they went to get the they made the effort to get the medication again. Now, if there's automatic bill, that eliminates that and then because it doesn't work. But if you require someone to make an effort, you can imagine that someone's not going to make the effort for a medication if they're not taking. Why bother going? Well, I'm not taking the medicine, but I'll go to the pharmacy and get a refill, or I'll call. Nobody's going to make that effort. So typically, for human behavior, they'll get refilled because they're taking medication and they're almost out. And I think that would reduce that. But again, it's going to be a decision. And I'm sure people can come up with examples where I have it wrong. Let's say it's an example of a drug that is used and sold. Maybe they're not taking it, but they sell it and make money off of it, profiting from getting it. And so they're not actually sharing their profits themselves. So each of these potential flaws, identifying in your drug disease study what is critical, and then you can make rational decisions about whether you want to use percentage-based cover or medication ratio, how to address that potential.
Yeah, and it's another reason why we sometimes require patients to have filled twice for some studies, because we assume that the first time maybe they didn't take it at all, but they're not going to fill it again if they never took it. So
Exactly.
yeah.
Yeah. So for CDC, the eligible members who, yeah, it has to be to refill.
Yeah, cool. Great questions. Okay. So the last couple minutes, I'm just going to spend on different ways now we think, you know, all these issue thresholds, continuous measures. This doesn't solve it, but at least it's a kind of a method that we sometimes use to think past, say, the 80th% threshold. So this idea is mostly stemming from the fact that adherence is relatively dynamic. It's a behavior. We're measuring whether patients are taking drug. And so these 2 patients shown here have 2 similarly calculated proportion of days covered, or PDC, both about 50%. But objectively, you're looking at this and you're like, these are very different filling behaviors. And that's true, which is what motivated. Are there other ways of thinking about how patients are using medication that might be meaningful. And so one method, there's other types of clustering based methods, but I'd say this is the most common one we use in the pharmacoepidemiology space, which is group-based trajectory modeling. And so effectively a clustering-based method that's taking into account kind of the timing of when medications are filled. So what we're really doing is breaking down these longer periods into shorter periods of time. And so for these two patients, we're calculating over, say, a 12-month period, individual months, and how they're taking their medication. So we're starting the processing by measuring within each month, are they adherent or not? You could also measure continuously. There's several papers that PDS has published in the last couple of years, kind of talking about the different types of approaches to trajectory modeling, pharmacoepidemiology drug safety, the main journal here. But basically, you're starting from breaking down these methods. And so trajectory modeling is effectively estimating a logistic regression model for here, if we're treating each month as dichotomous, the likelihood that patients are adherent in each month, assuming a set number of groups we think that exist in the data from data pre-processing we've looked at, as well as what group they belong to. So it's a simultaneous model estimation. You have to apply a couple of things. You have to assume there's a fixed number of groups, and you have to kind of assume, and this is the hardest one, that every patient assigned to those groups has the similar pattern. And so there's different ways that we kind of look at whether that's true. We look at the proportion of like the probability of patients assigned to that. We can look at different spaghetti plots to see whether that actually matches. But the idea is ultimately for each patient in our data, we get the probability of them belonging to a separate group, and I'll show you what that looks like, as well as what their predicted adherence was over time. So what that ends up looking like is within, rather than just summarizing the proportion of days covered or whether patients were adherent or not, we get these like fun little patterns across different groups in our data. And there's different ways of coming up with a number of groups that should be in your data. We're basically within this population of patients, say, taking statin medication, the model identified 6 different groups that existed. And with different proportions, percentages of patients assigned to the groups, and that the model predicted an actual adherence are the different lines. And so for group number 1 here in black on the top, about 23% of the sample was assigned to that. And these are basically patients you would have probably identified in the data already anyway, which is near perfect the whole time, filled perfectly. Then there's group 6, which is another 23% of the sample, which basically filled once. But what's interesting is you never would have found those middle groups necessarily by just taking the proportion days covered throughout, because actually they kind of have different patterns of how they took medication, but their actual averages, if you had drawn a line across, would have been similar. And other kind of subsequent work shows that some of these different groups do have different clinical outcome relationships. So it does matter, at least in some contexts, trying to get at this nuance of what's actually happening. And so these are just kind of different examples of different groups. Ended up for this particular study, I think this is the first trajectory plot of adherence, which is why I like using this one. It was published about 10 years ago. Different sizes of groups and sort of how it worked. And so really just kind of how it looks. There's, again, different clustering methods. This is the one that's really most commonly used. It's available for free, but effectively when you are programming it and running the models, you have to create variables about what their adherence is in each month. This is just the 1 to 9 as an example, what the time scale is. You have to give it the number of groups, what the order of those groups are. And what I mean by that is what the functional form is. And that's part of what you're testing when you're creating different trajectories and sort of comparing like what they look like compared with each other and what the fit is. And so you're returning the estimated trajectories and the predicted probabilities. And so you're kind of doing this over and over until you find the one that fits your data best. So there's a couple different metrics that we use for that, which I won't get into for time. but we can talk about more if you're interested in. But kind of my takeaway points in summary before we let you head on a break is that there's this taxonomy. Use the taxonomy: initiation, implementation, and persistence. We can measure adherence and claims. We can quibble, but probably the one you'll see the most is proportion days covered, at least here in the US, but medication possession ratio is common. I don't care which one you use. They're often the same and give you similar results. But really spend time, if you're doing this work, whether thinking about adherence as an exposure, outcome, or covariate, there's a lot more care that goes into it than I think I knew about before I really got into this field. So if you really want to learn more and actually do this work, starting, for example, with these emerged guidelines that were published in the Annals a couple of years ago about how to do adherence work by kind of our friends at ESPICOMP, I think is probably a really great place to start. So I'll leave you with that, and why don't we go ahead and take I think we're okay. Take a 10-minute break. I will come back at 10:55, and then we'll talk about the electronic databases and then move into the case study. Thank you.
Okay, so we heard from Julie about the different objective measures, but really focusing on pharmacy refill because that's what most of us in pharmacoepi use. But there are other techniques, and I'm going to go through the electronic techniques now. So the objectives are to become familiar with these tools to describe their strengths and limitations relative to validity and implementation, and to learn sort of how to think about which ones to choose in your setting. So you've seen this before, and the phase that I'm really focusing here on is essentially implementation, because you're electronically monitoring a med that the patient has. So they have to have initiated it. Otherwise, you can't electronically monitor. And when I mean electronically monitor, I'm not talking about electronically monitoring a pharmacy database. I'm literally talking about the concrete monitoring of the medication that they have in their hand. And essentially, you're monitoring implementation because you're going to have very precise measures of date and time down to the minute of when they took the medication. You can use it for persistence. It's quite an expensive way to measure persistence because there will be no events triggered by the monitor. And so that means they stop taking the medication. So you can use it for persistence, but most of us use it for implementation because if we want to get that really granular detail of the pattern with which they took their med. So here's a timeline for these methods. In the 1980s, John Urquhart, fellow of ISPE, may he rest in peace, developed the medication event monitoring system, which is MEMS and is often used sort of the way we use Kleenex for a facial tissue. It's almost become the generic name, but it's actually it's an actual product, and there are many products. And I'm not advocating any one product over the others, but it was the first. It was developed in the 1980s, and I'll show you what that looks like. Then over time, other techniques have been developed, and many other pill caps on bottle techniques have come and gone. Then they were adapted for inhalers and for eyedroppers. And then digital insulin pen, and also these blister packs that when you punch through the blister pack, it date and time stamps. So all of these techniques have been developed over the last several decades. In 2017, a digital pill was approved, and when I say a digital pill, it's the medication is packaged in such a way that when it hits stomach acid, it sends out an electronic signal, and that signal is picked up by a detector worn over the stomach, and that can precisely measure when the pill was ingested. And then a digital inhaler that I'll give you a little bit more detail about the digital inhaler, because not only can it tell you was the inhaler actuated, but for folks familiar with the way inhalers work, many people, I shouldn't say most, I bet it's most, many people use them wrong and don't actually actuate it into their breath. They sort of blow it into the back of their throat and then breathe. And so this digital inhaler can actually tell you whether the technique was right and whether they actually got likely to have gotten a dose based on the technique. So here are the devices. This first one is MEMS, and there are many versions of this. They're called a variety of different things. We just typically call them microelectronic monitors, and they go on a pill bottle that is usually sold to you by the company that makes these for a penny, and then they sell you these for a few $100s. And they go on the bottle, and every time the bottle's opened, it date and timestamps. But it's not simply a counter. So you can't sit there and go, okay, I'm going to fool this researcher. I only took it once this month, so I need 29. Okay, 1, 2, 3, 4, 5, and you'll know that they've tried to actuate it, and you can eliminate that in your analysis. Blister packs, you punch through the foil and it date and timestamps in a similar way. Inhaler monitor, which goes on the end of the inhaler and can measure that it was actuated, but also some of these can tell you the technique. And then here's an electronic needle container, which is very useful for studying insulin, is that when the needle is discarded, it date and timestamps. Here's how information is managed in these systems. You have the investigator who looks here like a physician, but I would take off the stethoscope and say it's good for a pharmacist too. They will then interact with the patient, prescribe the med, and maybe prescribe the monitor. If you're in a research study, you're getting consent to give them the monitor or give them the medications in a monitored way, such as giving them the medications in a monitored blister pack. So here's a simpler way to look at it. You give them the electronic blister pack, and then it date and timestamps whenever they've popped the medication out. Now, you might be saying, okay, sure, they're just going to pop the medication out, but they're not going to take it. Are we going to be compliant with the fire drill? I used compliant intentionally. Is that a fire drill or is that a fire? You have no idea. Okay, well, I'm not going to hang around and wait. So why don't we yes, they would. Words that we use are, let's get out of here, and then come back and I'll finish it. That's correct. Yeah. It's a measurement, not intervention. It can be used in intervention studies, but this is just, I'm just talking about measurement here. Okay, so just to summarize, there was another question as we were coming in, which is why go through all this effort if they don't help behavior? So first of all, what they do is they get you really granular data for describing the adherence patterns, which is often scientifically interesting, but they are paired with interventions very commonly. And so there have been companies that have tried to get traction in the marketplace of utilizing these, feeding the information back to an interventionist, and then intervening when the non-adherence is detected. Go ahead. So the question is, how do these data compare to claims data? So it's if you're measuring it for the same person, it's thought that these are likely to be more accurate. Certainly, they're more granular, more precise. They're thought to be more accurate than the claims data. There are a couple of issues with claims data. First of all, if you're going to Mark Cuban's cost plus pharmacy, those aren't going to be in claims because people are paying cash. If it's a drug that isn't under claim, so if you can put over the counter meds even in these. You're not going to be able to do it with claims data. And there is a study that's been done that used the microelectronic monitors, but when the people didn't want to use the monitor, they then used claims data. And most of the variability in outcome was measured by the microelectronic monitor more so than by the claims data. And so they're thought to be more strongly related to true adherence behavior than claims. So if you had both, most people would use the data from these. No, go ahead. Yeah, maybe ask the question again.
Hi, so I'm asking about how often this is actually utilized in RCTs to already get that information before the drug's on the market.
So I'm going to pause you there.
Yeah.
RCT of what?
We'll pick a drug, any drug.
Okay, but so you're saying, so just to be clear, you're saying an RCT to tell whether the drug works or not.
Mm-hmm.
I was thinking RCT of whether my adherence intervention worked or not.
Mm-hmm.
So you can incorporate, those are different RCTs and with different goals. So for my RCTs of did the adherence intervention, I've done AIDS clinical trials group studies, et cetera, using these microelectronic monitors.
Mm-hmm.
And we did it in order to measure adherence outcomes for an intervention we did. So it was incorporated into an RCT. How often is it in a drug development setting? I think it depends on if the company developing the drug really is worried that there might be medication non-adherence that might kill their drug, and they would want to intervene and do something about that. They would want to implement the microelectronic monitor.
Mm-hmm.
So if you did that, you wouldn't want to control for adherence comparing drug A to drug B, because in the real world, which clinical trials aren't, but in the real world, if you want to know if drug A works better than drug B, you compare drug A to drug B, and adherence was one of the variables that caused drug A to not work. So you wouldn't want to control for it. If you were doing analyses to see if drug A is efficacious, not effective, but efficacious, then you would want to control for adherence. So those are the different considerations. How common is it? If you went to the ARDEX website, you would probably, or I guess it's ARDEX now. If you went to their website, they'll list all the trials that their monitor has been used in, and it's hundreds. So there's a lot of data out there where these have been used. This is not new technology, and it is not obscure technology. This is just specialized to adherence. So if you're not working in adherence, you wouldn't necessarily have heard of these. You might wonder why they haven't developed and commercialized, and we can talk about that, but who's going to pay for it? is sort of food for thought. And I put that at the end, but we can discuss it now. Like, if you monitor these things accurately, who should pay for the monitor? Is it the company that's making the drug because they're making more money? Is it the pharmacy that makes money off of the drug? Is it the patient because they're getting the health benefit? It hasn't been worked out, and certainly hasn't gotten traction in a clinical setting very well, but certainly in a research setting, it's very well established. Okay, so the data comes. You bring your packet in. There are various device readers. This happens to be one of the more up-to-date MEMS readers, but it's sort of like reading for people who are familiar with pacemakers. If you're going to interrogate a pacemaker, you just basically put a transponder on it, and it downloads the electronic data, and then the data comes to your database, and then you get a pattern, and you can do myriad things with the data, and we'll talk about them in some detail. But essentially, you're getting the date and time the thing was triggered and activated, which we then know is strongly correlated, not perfectly correlated, but strongly correlated with whether the medication was taken at that date and time. Okay. Information goes back to the study investigator, and then what do they do with it? They wag their finger, they yell at the patient, they say, you've been non-adherent, and it does no good. So this is part of the problem, is we're not talking about adherence interventions here. And I do a lot of adherence interventions in my research. There are ways to deliver this kind of information and intervene that are good and destructive. And so the data can be used for bad purposes or good purposes, and in good ways and bad ways. We're not going to talk about that here. It's just the data is available. So here are just some plots of individuals. This is in 2014. These are individual days, and this is actually the time of day on a 24-hour clock. The person's clearly meant to be taking it once in the morning and once in the evening. And the green dots are they took it. If there's a gap missing, it means it was completely missed. And here, this is using the inhaler. The yellow tells you whether it was actuated and used properly. For the other settings, for the microelectronic monitoring of the pill bottle and the insulin syringe, and et cetera, you don't get technique. So all you would get is a green dot that it was actuated or an event occurred, and you'd get a missing dot when it didn't happen at all. And so looking at this pattern, clearly the person is taking it somewhere between 8 and noon every day, although they got up early this day because they had to give a talk in Halifax, and it was early for them. And this is not me. And then here they were taken in the evenings, and maybe it was midnight, and they fumfered around with it. They were tired, and they didn't do a good job of actuating it. Here's a person who's using it regularly. They're just not doing it very well because you're getting all of these yellow dots of where they actuated it improperly. If this were microelectronic monitor, this might be just completely very poor execution, where they took it a couple of times here. But to Julie's point, they were not non-persistent, because on your last day, they're still taking a dose. So there's still something about them saying, I'm still on the med, but I just don't do a good job of taking it when I'm supposed to. Here's that person in much better detail, where they're taking it kind of around the same time, but there's a lot of skew in the mornings. There's a lot of skew in the evenings. Then there's a lot of gaps in here, and then finally they're back on it. And then here's not a lot of data because they're not doing a lot. They're not taking it much. So the individual patterns are, you could just eyeball them. And eyeballing is very, very useful qualitatively. How you're going to quantitate it is what we're going to talk about next. But qualitatively, you would just look and say, like, this person's doing pretty well. Not a lot of gaps and pretty consistent timing. This person took a drug holiday, a phrase that I hate, because holidays are fun. Holidays are great. Not being on your meds is not great, especially if you're taking a drug for a really critical disease where it really is important that it works. So this drug gap, this is an obvious drug gap. This person it looks like a mouth with a lot of teeth missing in it, and it's because they're missing a lot of doses. So their implementation isn't great. And this person, well, we think they were switched from actually metoprolol to atenolol. Here they went the reverse direction from Julie, so they went from a twice-a-day drug to a once-a-day drug. You'd need that confirmed with other data, because it's certainly possible that the person was like, I don't feel good when I take it right before bed, so I'm only going to take it in the morning, or I'm going to double the dose in the morning, which may not be equivalent, right? The same double the dose once a day may not be the same as the dose twice a day for certain drugs and diseases. And this person, there's just nothing there because they're not doing anything. So looking at those patterns, it's clear to you who is who. But obviously, we're quantitative scientists. We need to put numbers on these things. We need to assign them good or bad, or 97% versus 13%. We need to put numbers, and that's what I mean by summarizing the data. So you can use the traditional measures. You could do all of the things that Julie talked about with the pharmacy data, but there's much more you can do here because of the granularity. So you can assign a percentage of days covered or a medication possession ratio, because you know the day they started, you know the day they ended, and you can just simply count how many doses they took. But these are much more sophisticated than simple counts. And if that pattern matters, then you want to capture that pattern. And that's what I'll talk about with the analyses. So you can think about initiation, because you gave them the blister pack when they came in, and then they just didn't even pop one through, then they were non-initiators. You can look at persistence, often for short term, because the question was, how often are these used? And they seem impractical. You can't study millions of people with them, and you can't study them for 15 years because the batteries run out, because people might get tired of them, because it can be inconvenient, and their medications change. So you can do short-term persistence for as long as you have your active cohort, but you can't do many, you can't do decades of persistence. The cutoff challenges that we talked about before, and we went into great detail on, are completely relevant here. It's the exact same issues. There's no difference than the discussion we had during Julie's presentation. I mentioned this in the hall when we talked about why would you bother doing this? Because you don't get data on what happens on Fridays from the pharmacy refill. You just know that they came in and they took 30 days supply in 40 days. So they were 75% adherent from a medication possession ratio, right? They took a 30-day supply. It took them 40 days to come back for a refill. So they missed 10 days. Which 10? You're assuming it's the last 10, but it might not be true. It may have been the 3rd day, the 7th day, the 9th day, the 10th day, the 11th day, the 13th, et cetera, and then count up to 10. We don't know where those 10 happen. When you have the microelectronic monitors, you know which 10. And if 4 of those 10 are Fridays, or 8 of those 10 are Fridays, something's going on Friday. You might want to talk to the patient and say, hey, what's going on Fridays? Oh, Fridays. And then you start to get to the story that can lead to interventions. And again, we're not talking about interventions, but it gives you that ability to get to granular data and really drill down on what the patient's doing. And then for the actuated inhaler, you can measure the quality of intake for an inhaled drug. So how do you describe these patterns? How do you summarize them? And there are myriad ways of defining pill taking. And the choice, I'm going to harp on this again, it should be based on clinical relevance. It's going to be based on the drug and the disease. I'm not going to give you a number for your drug and disease, because I don't study your drug and disease. I study HIV and hepatitis C and infectious diseases. So I can give you suggestions there, but I'm not going to give it to you for the disease you're studying. It needs to be based on pharmacokinetics, pharmacodynamics, and what you know clinically about how much exposure somebody needs of their drugs. The easiest to comprehend is what we've been talking about the whole time, is the percent of doses taken. Now, when I say easy to comprehend, I mean easy for you to comprehend. I don't mean easy for patients to comprehend, because people's numeracy is much poorer than we think. And we're a highly educated class of people, and we are much better at understanding what we mean when we say 75% or 90%. Whereas other people, if you say 50%, they don't really know that you mean about half. And I'm not trying to make fun of people or belittle them. I'm just giving you the reality that numeracy is not as good as we often perceive. But for us to communicate, we can talk about the fraction of doses taken. And we, when I say 75%, you're like, oh, they're taking most of it, but not all of it. 99%, oh my gosh, they barely missed a single dose. But that may not be the most clinically relevant, as we've discussed in detail. Are there better choices? So here are 3 patterns to just give you a very stark example of the problem of 50% adherent, where patient A is on twice-a-day regimen for 10 days, or you could say 10 months, whatever you want. But let's say 10 days, they're on a twice-a-day regimen, and they take it perfectly, and then they stop persisting. They discontinue. Patient C falls asleep before their second dose every single night. And patient B, the sun and the moon and the stars don't align for them every other day. So they have a funky pattern like this. And there are infinite number of patterns possible. And yet you would simply call all of these people 50% adherent. But that might not be the most clinically relevant, because I can tell you in HIV, we worry that this person is feeding little bits of drug to the virus just so it can become resistant. Whereas this person is going cold turkey and has no drug on board and may die of AIDS because they have wild type virus replicating in their body. And so I want to know these different people. This person, I have no idea what's going to happen with them, but I kind of want to know how they differ from the others. So you need other metrics other than the simple percentage of pills taken. So you can, so the mean doses per day is essentially the percentage of doses taken, but how long is the time interval or gap? What is their average time gap between doses? Or one of my favorites is the coefficient of variation. You take the variance. How much wobble is there between their doses? So they take it at 8 one morning and 8:15 the next morning and 7:59 the next morning and 8:03 the next morning. And you're like, wow, that person's really clustering around 8 o'clock. And then some people, they take it at 6, they take it at 10, they take it at 5, they take it at 11, they take it at 6:30, they take it at 9:30, and there's much more wobble. You might think that the person with less wobble is going to do better because their drug concentrations are maybe more likely to be constant. And so their coefficient of variation should be smaller. So the lower coefficient of variation one has, the more adherent they're likely to be. But that might depend on how often they're taking the drug, because if they only take it twice and they take it perfectly at 8 o'clock and 8:01, and their variance is very tiny, but they've only taken it twice, it doesn't matter. So you want to divide that by the mean, and that gives you the coefficient of variation. I love this measure. It just took me about a minute to explain it to you. Think about trying to explain it to a patient. Forget it. Trying to explain it to a doctor is often difficult. So these measures, even if they may really capture what you're looking for, if they're hard to communicate, may be science for science's sake and be useless clinically. There are other ways of doing this. We could talk about all sorts of ones. How long was your biggest gap? If of all your gaps, you're supposed to be 24 hours, 24 hours, 24 hours, 24 hours, and then you go 72 hours. Okay, maybe it's 70. Oh, no, and then you went 96 hours. That's your longest gap. Whereas another person, they had a gap that may have been, their longest gap was only 27 hours. So comparing those people with a really long gap versus a short gap, it depends on your drug and your setting. So the pros of these measures are they're non-invasive, but they are objective, and they're very close to real intake. They give you the very granular data that I described. You don't need large electronic databases, and they are considered the gold standard. They're not perfect. So a tarnished gold standard is a oxymoronic phrase, but because gold doesn't tarnish, but they're imperfect, but they're considered the best we have. So in the question of if you had this and pharmacy data, you'd use this. The cons are there are technical issues. They may not record. People might find it annoying. Take out a week supply, put it in their pants pocket, and only open it once a week. And so you underestimate their adherence. The batteries can die. They can be left back in the bad old days during the crack epidemic in the United States. I've had them left in crack houses. Crack houses don't exist anymore because of patterns of drug use in the US, but they were left there, and I left them there and did not go try to get them. So they can be lost. And boy, oh boy, I'll tell you, people's hands are dirty because when these come back, they come back grimy. Because people are, they're opening and closing them, and they're not meant to be washing them. There are issues of privacy and data sharing that we could talk about. Cost is clearly an issue. We went into some detail about that. There's no guarantee of actual drug taking because you can't open it and toss it away. That's really, really pathologic behavior and would be very unusual that you have a drug, you have a disease, that terrible disease, you have a drug that your doctor prescribed, and you're going to mess around with the adherence researcher by going, I'm just going to throw that out. It's not going to happen. What happens is they come to their visit, they either do this with the cap, or they'll toss all the pills because they're nervous about still having pills, and they're going to be scolded, which still a lot of people scold patients remarkably, which I think is idiotic, but they do it, and scold the patient for having done that, not having taken their meds. And so they'll throw it out. In those cases, you only have one actuation event when they threw out all the bottles. So you'll misclassify them by a minimal amount. And then what do you do if you have multiple meds? That's a problem. So ask your question, because I'm going to then go into food for additional thought. And I think there's a microphone that can go around. And then Julie, our timekeeper, is going to tell me how long I have to discuss for food for thought. And okay, great.
Obviously, it might depend on how long the study is for, but because you're using an electronic method and the patients obviously know like it's to measure adherence, do you think that subconsciously they're like, okay, I'm being measured, so I'm going to do a better job. I want to be a good participant?
Yeah. Yes. So that's been studied in detail. So, we refer to that as the Hawthorne effect. And I think it comes from Hawthorne somewhere in Ontario, maybe? I'm not sure. But it was a study of hypertension, and it was thought that the people, because they were being monitored, changed their behavior. So if only people would change their behavior because we were monitoring them, that would be wonderful, and then non-adherence would go away. So it's been studied in great detail, particularly with microelectronic monitors. And what I tend to do is and I have a paper in, I want to say Jade's, but you can look it up. It's probably from 2002, maybe, where we put a microelectronic monitor on people's bottles when they were starting antiretroviral therapy, and looked at 4 months, did they have treatment success? And over the first month, the people who had treatment success versus treatment failure had an equivalent amount of adherence. They both did great. And then the people who started to fail started to drop off later. So one way to deal with that, so we think it's maybe for a month that it's in the back of their mind, and then they just get kind of used to it, and they get kind of, used to the fact that they're being monitored, and then their lives go on. If they're not paying attention to their disease and they're worried more that the doctor's monitoring, there's something else going on with them, because you got a disease where the drug works and you're more worried about what the doctor's going to think, maybe for a little bit, but that wears off. So it's not a big, Hawthorne effect is not a big problem with these.
Thank you. Has this ever been paired with a behavioral intervention?
Oh, yeah.
And what happens? Everyone has a smartphone. And does that work? Does that help?
Yeah. So there have been a lot of companies that have developed apps to monitor people to monitor adherence. So that's the first question, I think, is, are there apps to do this? And, you can actually gamify them. You can put in whether you adhered or you didn't adhere, et cetera. They have some effect. The main problem is you have to be adherent to using the app. So if you're not using the app and you're non-adherent, I can't say, well, you just didn't use the app. Maybe you just took the pills. And so you get into this problem of the people who use the app are good at adhering, and the app, they say the app helps them. And the people who are not using the app may say, oh, I'm still taking the meds. I do fine. So that's one challenge. The second is the ideal system would be you monitor adherence, you use a Bluetooth system for the monitor. And this is not science fiction. This has been developed by a company that I was working with that hasn't really taken off. Through Bluetooth, it sends a signal to whether the dose was taken to a central database, and then somebody just checks the central database every day. And if you missed a dose, you then call the patient, you say, hey, you missed a dose. And then they'll say, oh, no. I took out 2 this morning, and I took, because I was going to be away and I wasn't going to be home where my bottle is, so I took the second dose. Okay, that's fine. Or they'll be like, really? I missed a dose? I don't miss my doses. Well, the main reason for people missing doses is forgetting. And you probably just forgot because the monitor is tracking you and says you didn't take it. So let's talk about what help you need for forgetting. Those interventions have not really taken off because they're very time intensive. And again, at the end of the day, if they work, who's going to pay for the monitor? And so people aren't spending a lot of effort on pairing those because there's no money in it for anybody. So the stuff that I've worked on have been behavioral interventions where we use self-reports and viral loads and other techniques to track people, and pharmacy refill records to track people's adherence, intervene with them individually, because there is a reimbursement model for counseling. So that's the model that I've followed. And so now you're sort of extending this conversation from beyond measurement to, okay, you measured it. What the heck are you going to do about it? Like, try to help somebody, which is what I focus on. I think a lot of people in here are interested in the measurement because they just want adherence to go away. They just want it to be like, I'm studying the drug. Don't tell me about all the crazy things people do. I want to understand, is the drug safe? Does it work when people take it? Make adherence go away. And that's when you control for adherence, or you just stratify, you only study the people who've been taking it, for example. And those are, I'm going to come back to the same mantra. The question is, what is the question? What is your goal? What is your focus? And so these monitors serve some of those purposes. They don't serve others. Do you have time for one more? Go for it. Yeah.
I was just reflecting on your comment that, having these devices paid for in a clinical setting, it's hard to justify to push onto one person. And I was wondering, it seems to me that the only potential people that'd be interested in paying are payers, because they're invested in preventive medications,
Yep.
lowering worse outcomes.
Yep.
But following that vein, do you see that argument as a suggestion that from our perspective as researchers, that we have to be the ones providing the data that justify that the companies can use to argue for that?
So it's a terrific idea. I'm with you 100%. The issue is, what's the time frame for the relationship between adherence and the outcome? So let's say I'm a private insurer and I don't want bad things to happen to my insured clients because they're going to cost me money. But their adherence to their antihypertensives now is going to cost Medicare for the elderly 20 years from now. I don't reap the benefit. Medicare does. So I think those are the kinds of, I'm not a health economist, and I'm certainly not an insider in any of these decision-making mechanisms, but I can imagine those are the conversations that go on. Another point that I thought a direction you were going to go in is, why don't the drug manufacturers, which make a lot of money off of these drugs, build adherence interventions in? And the problem there is, unless you can tether it to their individual drug, everybody's going to. So then, why am I paying for that company's drug to be taken better? I want it to be my drug. And so one company, for example, developed a schizophrenia drug and packaged it with the monitor that you wear you tape the monitor to your abdomen over your stomach. And then that's what measures the signal of the capsule hitting closing the loop of the ions on the capsule and sends a signal out. They paired it together because they just wanted it to be proprietary, so that if they were going to build this, if they were going to pay for this system, their drug would be the only one that would benefit. So it's what happens when you're in a system where it's this blend of capitalism for selling drugs and buying drugs and using drugs versus who benefits and where's the money saving. And I leave that to health economists. Great. Should we move on into the
I
into
also
the
have
session?
I
Go for it.
also have a question. Actually, we are a little bit advocating that electronic monitoring is the gold standard, and I also said that. But I increasingly getting doubts about it, because what also my experience is that non-adherent people don't want to use these electronic pillboxes. And the uptake of using electronic pillbox is very, very low. What do you think about
Yeah,
it?
so I think it's a great point. It's very similar to my comment about the phone apps, is that these apps have been developed and the adherent people are all excited about them, and the non-adherent people are like, I'm not non-adherent, or I don't care about this. I've got too many other things going on in my life to interact with an app. It's the same thing with these electronic devices. The people who are really committed to them may be the adherent ones, and the people who are not committed to them are the non-adherent ones. It may actually be one of the reasons why they strongly correlate with outcomes. Because if you're not using the cap because you're non-adherent, it doesn't trigger anything, and you're like, I don't even bother with that thing. They're probably actually non-adherent, and the people who are really committed to using it regularly. So you could probably even just say, I can make an analogy in the HIV world. When you come in, the goal of HIV treatment is to get the HIV virus undetectable in your plasma. If you come in to get your HIV viral load measured, the likelihood that it's undetectable is probably something like 90%. And if you don't come in to get it measured, the likelihood that it's undetectable is quite low. And so don't do the assay. Just have them come in, draw their blood, and say, okay, you had your blood drawn. Your likelihood of being undetectable is 90%. And it's the people who don't come in are the ones who need to worry about, which is, again, it's a missing data problem. It's the people we don't have access to that are the challenge, and we're missing data on them.
And I think this is again a combination of the disease and the medication, the effectiveness of the medication, pharmacological properties, and choosing the best available measurement methods.
Absolutely.
And the best is to use 2 of them.
Great. All right, let's see if we should load do you know how I load the presentation?
The case study.
Yeah.
It should be here, but I don't see it. Yeah.
Is there a way I can call it up from the website, you think?
No, but we have printed it.
Okay.
And in the preparation, our participants could have seen it, but for the convenience, we also printed it.
Great.
And
I can take the other mic and just walk around.
yeah,
We should group
Yeah.
people.
Yeah. And I suggest we make 2 groups of 4 people. If you are
3 groups of
4, and there are 4 people, and you
3 groups. 3 groups.
3 groups.
3 groups.
Okay. 3, 4, 5. And here the other group. Yeah. 2 groups of 4 and 1 group of 5.
Sounds great.
Yeah. Sounds fine. And the essence of the case is we have a case with 2 assignments. Yeah. 5. No, not to read it out, but just very short explanation. Yeah. Summary of the case. Yeah. Yeah.
Awesome. Okay. So, Kathleen, are you gonna introduce the case, or how do you want to go into that?
Sure. Okay.
So we'll see how far we get. We got about 40 minutes. You've had great questions. And so basically this case description will go in probably 2 segments, but the idea is you have a new job and you're concerned about diabetes medication use in your population in your country. And you know that adherence is probably an issue related to it. So you have a lot of interest in your population and understanding the extent of non-adherence, kind of what the problems are, and sort of understanding patient level data a little bit. So your first task with your group, pretending like it's your job, is to try to understand the extent of diabetes non-adherence in your population. And so say, for example, you do have nationwide pharmacy dispensing databases available to you. So with your group, work through assignment 1, questions 1 through 4. We'll see where we get, and we'll kind of come together and sort of discuss those together. But really, what's your study population? If you're thinking about diabetes medications, kind of what are you interested in? Like, we've had a lot of, it depends. So this is your opportunity to sort of put your stake down and sort of how you would go about thinking about how to understand non-adherence in your population. Which of the 3 adherence constructs would you be most interested in studying as your group? And then kind of how would you go about measuring it? So we'll start with that as sort of the key thing. Questions about that? So we'll spend maybe, let's say 10 minutes, see where you get. And we'll come back together and then discuss those as a group. And we'll walk around and sort of give you some guidance. Cool. How are we feeling on time? It's okay if you don't get to everything. What question are each of you? I think they're done. It's okay if you're not. Three. Okay. We'll give it about maybe 2 more minutes and we'll just see where we're at. Cool. All right. Oh, okay. Yeah. Cool. Well, I'm hearing some really good discussion. But what I think we'll do and what I suggest we'll do is just spend the balance of our time really focusing on assignment 1 rather than trying to rush through 2 and 3. And then we'll have a little bit of hopefully time to kind of close out and see what questions people still have. So maybe what I'll do is I'll just ask the question, and Robert, Jacqueline, if you want to hop in, and we'll start like one group and sort of alternate what people came up with. So what did people end up with for how you'll define your study population? Maybe I'll start with the group right here on the front. How about I go 1, 2, 3, so it'll be a little bit easier to define it. So group 1.
So we argued for a new initiator design, just since we felt that prevalent users are sort of like conditioning on their past adherence, that, you know, if they're prevalent users, they had to have been adherent sort of up to that point. And because we're interested in, you know, whether people in sort of the trajectory of their adherence, it's easiest to sort of start with people who are just starting.
Okay. Great. Did any other group kind of think about something else in terms of new initiator versus prevalent user and other aspects of the study population? Maybe group 2, yeah.
We went even a little stricter with the new user design, also newly diagnosed with diabetes, because we wanted their baseline HbA1c, so we could really clearly monitor and have their baseline so we can see if they really are kind of adherent or not.
Interesting.
Long term.
Yeah.
We're assuming it's captured in the database.
There we go. Okay. Assuming HbA1c is captured in the data. Yeah, the new so with adherence work, I'm just going to chat for half a second. We often get asked, well, do patients really have a diagnosis of that condition? And are asked to also require a new diagnosis of something when we're studying adherence studies. I feel like I've always tried to make the case that if patients are by and large taking the drug, that's a more specific indicator than a diagnosis, which we know is often underdiagnosed in claims, but people could quibble with that. So I like what you're thinking about, which is it's not just new initiation. Like, we really want to be sure someone's new. We also would like a new diagnosis. And then there's the associated washout windows. So what you may miss is people who are somehow the windows are mixed, or there are people who are just not diagnosed, even though they're started on a medication. But at least if we know they're taking it for diabetes, they're not taking it for PCOS or something else where that could be another condition. Anyway, great thoughts. Group 3, what were you thinking?
Okay, I have been voluntold. we said we would, this is like maybe more specific than we need to be. We said we would do like a more longitudinal retrospective cohort study where you identify new users and then follow them forward to like whatever your end of follow-up period is, so that you eliminate prevalent user bias, but you can clearly see like, okay, what was their adherence during that time, and did that have an effect on like the effectiveness of the drug? We said we would stratify by different age groups, because obviously different age groups have different indications, and older subpopulations will have multiple comorbidities. They could be taking lots of more drugs for that have all contraindications, which is also going to be important to consider.
I just want to ask a question in response to your point about the prevalent user versus the new user bias. How do you think the bias might operate in this kind of setting?
Yeah, so basically this is like a fake study group. So the new user and the prevalent user could be different from their stage of diabetes, for example. They have different medications, like a first line medication, second line medication. So usually for me, because I'm a biostatistician and also computer scientist, when I do this study, I always include more variety, new and old user. So, but I create an indicator. So with this indicator, I always could stratify to find more difference between these users. But for different purpose of study, for our group, we do the new users. But in my real life, I probably include them both, and then to have an indicator.
I think to your point is, when someone's prevalent user, they're already technically considered survivors of the medication or even their disease state. So that's where it can add some bias, where if you start everyone on the same baseline, then you can actually fairly assess the drug effectiveness.
So, for example, if the medication causes side effects in a subset of people and those side effects lead to non-adherence, you wouldn't detect it in your prevalent users because you've already culled out the people who decided not to adhere to it. So you would capture that. If you weren't interested in how side effects impact the outcome, you might want people who tolerate the drug, and then include the prevalent users, because they've tolerated it. Now, how do they execute it? So again, it would answer a different question. Your point about bias is quite clear for the type of question that you want to answer. For a different question, that bias might not operate.
Define the research questions. But that's what you can explore.
I think our group talked a lot about this with whether we include switchers. And so I think it really did come back to the research question, because we initially said, okay, we want new users, because then we're not biased by their previous adherence. But then we started thinking about, well, if they have like big side effects and then they switch to something else, like they're still adherent in the sense that they're still on something, and still taking medication. So do we censor them and say they're not taking the medication that they were assigned to at the start, or do we like keep them in the study and characterize that as an outcome?
Yeah, so a way to characterize what you're asking is, are you interested in, are people adherent to this medication, and name the medication, or are they adherent to their diabetes care when you initiate them on this specific drug? And even if they don't tolerate it and switch to something else, you might want to consider them actually adherent. They're just not taking that drug anymore because they didn't tolerate it. Great points. All of which are different research questions that would need to be defined beforehand.
Great. So maybe you started getting at question 2, which is great. We started talking about switchers. Any related to question 2 and thinking about switching? I don't know, group 3, did you have any specific thoughts about handling switching and what you decided to do?
Thank you. So usually for my real life, we use GPI code. So
Okay.
yeah, for example, diabetes, anti-diabetic, the drug, I think the first two is a 27 or 24, 27, like for the GPI.
Okay.
Yeah, so basically, I think it's a little bit transparent for us if they switch, as long as they have starting with 27, for example. Yeah, for the GPI.
Great. Yeah, so you allowed within a certain GPI, but basically what that's approximating is a class, like allowing within class switching. Okay.
Yeah, we didn't talk so explicitly, but just to add to
Yeah.
that comment, I think for me, if I looked at it, depending on what the question is, it would be whether that switching falls within their continuous use period. So whether there's a big enough gap where they would be discontinued and then started, I don't know if I would include them. But if it was within a time period that it's clear that this medication didn't work, so they just switched to a different brand, maybe it was generic, I don't know, then I would still include it under the same drug class if it's for the same indication.
Smart. Group 2, anything you want to add?
Getting at the main question, and if it's adherence to that one drug, then maybe we just not include anyone that switches.
Yeah, and also depends on like the purpose of your study. One of the study I did, like we focus on very deeply for diabetics. So we very kind of like pay attention to each single drug,
Yeah.
although they're in the same drug class.
Yeah. What were you thinking about in terms of, we talked about switching, multiple medication use? Where did you all land in measuring that?
We talked a lot about like the multi-indication, specifically with like the GLP-1s and like the Ozempic stuff coming out, and how we like probably wouldn't include members who are just taking a GLP-1 because like there's a good chance they're doing it for like weight loss. But like if they were taking like multiple medications, like including a GLP-1, we'd probably assume that the members like supposed to be taking those, and we would like include the multiple medications and like sort of like quantify based off of like multiple medications.
Yeah, also in our question number one, for the population, we based on the diagnosis first, make sure they have diabetes type 2, for example, or type 1.
Yeah, that is increase. I love that you mentioned GLP-1s. I do a lot in diabetes, and clearly there's kind of this evolution that's sort of happening around GLP-1s and this school of thought that they could be used for obesity and exclusively obesity and not diabetes as an indication. I don't think we're quite to the point where, you know, we have to change the way we're measuring or dealing diabetes, but I think what you're getting at was a good reminder of it's not, sometimes people are using these medications for other things. And I've always just been like, okay, PCOS, like metformin, but you're right, GLP-1s increasingly for weight loss. And so being careful about other indications and sort of how we're handling those is important. So I like what you were thinking about there. Other thoughts about multi-medication use? I don't know, Robert, Jacqueline, feel free to hop in if you have thoughts too. Yeah, please.
One thing our group talked about, which just kind of, I think, adding on top of what's been said, was thinking about multiple medication use as almost an escalation of therapy, and still just seeing it potentially as part of their diabetes adherence. But we had thought about trying to classify oral agents separately from like injectable agents, and more considering that a type of outcome and something of interest to understand what's happening on these people's diabetes trajectory as well.
Yeah, I'm glad you mentioned injectables. So we haven't talked about injectables. We've mostly been talking about oral chronic medications. Why haven't we really been talking about injectables? Yeah, please.
I kind of thought about it as soon as I was talking with them, and I was like, oh, those are a mess. They don't, they're used as needed, and it's not a guarantee. You have to, particularly with insulin, modify the dose based upon your glycemic levels. So there's not a set end date on that prescription.
Yeah, that's definitely one of the issues for sure, is the way a lot of injectable medications, the way in which they're dosed and what the day's supply would look like in the claims that we're using for the oral medications can be a mess. There's so many assumptions that go behind it. And so we don't, at least I don't trust those as reliably for adherence calculations and doing the proportion of days covered or the NPR in the same way that I would for the oral medications. When we have historically done injectable medications, there's, again, depends on whether you're talking monthly ones, people use daily. I've usually kind of mostly focused on persistence measures because those are just cleaner and I can have a better sense of whether people are injecting. But of course, everyone kind of has a different school of thought, but that's my school of thought on it. Please.
I had a question for you on that then, because, you know, insulin's important therapy, obviously, right? And it's arguably more prevalent for those with type 1 diabetes than for type 2. So I wonder if you take it out in your main analysis, but then you include it as a sensitivity analysis to see if there's actually any difference. So would that be an appropriate approach to it?
Again, it always depends on your study question, but I love what you're thinking about in terms of sensitivity analyses and sort of calculating it that way. It also, when we've done these types of studies, there are some injectables where there is a routine, you know, what the days, like how often it is supposed to be given, and which, say for osteoporosis or something. So there are situations where you feel like you would know what the cadence would be. And so treating things as a sensitivity analysis or subgrouping on those who also use insulin and evaluating their adherence separately. I think the key thing is just knowing what you're measuring and what the limitations are. But I like where you're going with that.
There's one slight complication in all of this. There's a lot of complications in all of this, but there's another slight complication we haven't raised, which is in the setting of diabetes and in some other diseases, your adherence to the diet also matters. So if you're adherent to the medication, so it would add variability to your relationship between your medication adherence and your hemoglobin A1C. So for example, if you want to set a threshold, you're going to have some people who are taking 80% of their med and they're not controlled, and people taking 50% of the med and they are controlled. Because the person who took 50% may be someone whose diet is very controlled, and someone who's taking 80% may have a diet that's not very controlled. So this is why HIV is sort of a purer setting to study these kinds of thresholds, and we've spent a lot of time doing it, is because the only thing that makes your viral load go down is antiretroviral therapy. But in diabetes, it's your diet. In heart failure, it's your salt intake. And so now, again, paying attention to your setting, and we'll probably get into this with if we have time for assignment 3, is interviewing the individuals about some of these other issues will be critical because you're not going to get those data elsewhere.
This is just because I don't know what's recorded for diabetes. Are insulin patches information that we would have, like, you know, like they're computerized and automated?
So probably the dispensation of those devices originally, but not
the actual administration that they like.
No,
get
it
from
depends on what was filled.
Okay. Yeah,
yeah.
like the pump patches.
Yeah, you would probably just get that someone had a continuous pump in claims data, and not like what the actual values are, unless you're pulling that data from patient generated health data or something. Do you want to add something? Yeah.
Never mind. I understand. It's what we were talking about before, where like the dose of insulin and timing and all that depends. So you would just get that they had it and then it was used correctly, I guess.
Yeah, exactly. Yeah. So you wouldn't know the day over day nuance, and some of the injectables have the electronic monitoring associated with them that Robert was getting into because of this day over day information about how they're taking their insulin, for example, being really useful and interesting and necessary to measure. So anyway, we probably won't get to the patient interviewing stuff. We only have like 8 more minutes, but
Yeah, you need a complete picture of the indications, the co-medication, the use of the co-medication, lifestyle of the population, and compare the population and the behavioral aspects and lifestyle of your population with the population investigated in the randomized trials.
yeah. So what adherence constructs did you land on? Anyone want to add? Yeah.
A1C is supposed to go, but like, you know, measuring A1C level. Yeah.
Oh, so you were also interested in measuring A1C level as like an outcome.
Yes. As like a proxy for adherence. Like if it was going
Oh.
down,
Okay.
then we'd assume at least like either it's lifestyle or adherence.
Okay, sure. And that's a great point. And were there other things like, it sounds like most of you focused on the implementation construct phase of adherence. I was probably unclear on what I meant. Did anyone else sort of think about other phases you were interested in measuring?
And would you measure discontinuation? Yeah. The rate of yeah.
Yeah.
Yes, yes. And depending on the disease, they will decide to stop with it or not. When they are afraid of recurrence of cancer, they may go on, but when they can't walk anymore because of the side effects of statins, they may stop with it.
Great. Okay, last question. MPR, medication possession ratio versus proportion days covered. I know I spent 0 minutes talking about MPR. What did you end up going with and why? For anyone who has thought about this before, or you were just like, we didn't have time to get to this, which is okay too. Anyone who had time to get to it, what did you decide? Yeah, please.
Also based on not an expertise in MPR or PDC, but we said likely to go for PDC, not only because it's a very commonly used measure, because I know MPR as well, but because of the difference of actually taking proportion of days covered versus all the fills in the time period, which MPR does. So you have the potential to inflate the prescription fills for those who regularly get early dispensation and early refills.
So inflating with the medication
Yeah.
possession ratio. Robert, do you want to chat about the difference between the two of them? I think you do a really nice job
Sure.
with that.
So, because I think the PDC could also inflate in the other way. So what happens is PDC says that if you fill it, you get all the days that fill counted for you. So you fill it on day one, and let's say it's a 30-day fill, you get those 30 days for free. We only start counting your non-adherence if you don't get it on day 31, day 32, day 33, day 34. Okay. And that's because the PDC assumes once a medication is filled, it is entirely finished. So the advantage there is that if they've filled the drug and they've gotten some exposure, then you wouldn't know it from a medication possession ratio, because medication possession ratio says when you get the second fill, that closes your time interval. And it says, okay, they filled it again on day 40. So we know they only had 30 days supply. So they took 30 days out of 40. Whereas for the PDC, it's assuming those first 30 days. Okay. So if you want to declare somebody completely non-adherent because they filled it, but then they never refilled it, that person gets 0% adherence for the medication possession ratio, because it's never closed. So they have no end date in sight. You assume they took none, whereas the PDC assumes they took 100%. So in that extreme example, they're completely different. What happens over time, though, is they tend to even out and become very close to each other. So a person who's taking it in general, and then they get toward the end of the year and they refill a couple of days late, the MPR might discount those last couple of days, whereas the PDC would say they're fine. So for example, in MPR, if you came back, you were supposed to fill it on December 31st, and you came back on January 2nd, no, the year's over already. I can't count that last prescription. They've only gotten 11 prescriptions out of 12. So they're somewhat non-adherent. They're in the 90s.
Yeah.
Whereas the person whereas PDC, that last fill in November carried them through December 31st. You didn't have to worry about the next prescription. So these are subtle differences that they each have assumptions. you can think of them essentially as the same, that they're gross pharmacy measures of are you taking the meds? And then, geeks like Julie and I argue about them, but essentially most of the data suggests whichever way you do it, you're going to get close to the truth.
Yeah. Great.
Go
Oh,
ahead.
yeah, please.
I did on a new user design because we were really interested in sort of that initial side effect profile and how that impacted adherence, that the NPR may actually then be better if we really do want to capture people who, started it, felt terrible, and then never filled again.
Exactly. And those people get assigned non-adherent, whereas for the PDC, they would be assigned as adherent, at least for those first 30 days. And then, Julie might argue, well, I don't want to know just 30 days. I want to go more time. So let's go the first 60 days. So for her PDC now dropped to 50% because she gave them the first 30 days for free. The next 30 days, they get nothing. So they get 30 days out of 60 for their PDC. And the NPR gives them 0. Still 0 and 0 versus 100% and 50%. You with me? So if 50% is below her threshold, she's picked up that non-adherence that you were worried about, and she would probably put it into her design such that the PDC would reflect some of that early non-adherence, because you don't just stick to 30 days. You start with, let's say, 60 days or 90 days. So there are ways to make them start to look more similar to each other.
Yeah. All right. Really nice job. I know we're at time. And so I think everyone's probably clamoring for lunch, but just thank you for your participation. This was great. We can stick around for a few questions if you have them. Probably 2 things I'd like to highlight. Maybe Robert or Jacqueline have more, but one is, if you are motivated by this area, there's a special interest group that's adherence to medication. The meeting is tomorrow night. The information is more in your book. And there's also always, we sponsor a spotlight poster walk that's on Saturday this year. In the B session. So we've clustered together some adherence related posters as well as other kind of sprinklings throughout. So just attend the meeting if you're interested in the topic. Cool. Thank you.
Yeah, then I have a last thing. It was a real great pleasure to work with you, and I want to thank you for your participation.